Good morning again. You're getting a double dose. Welcome to the Lupus Symposium. As I was saying, it's a Sunday morning, and most of you would have been in church, I think. So I'm going to ask you to stand and greet each other in love and peace. Could I ask you to stand? Jesus loves you, so do I. Thank you. It's so great to be here again sharing with you. And I think that when we gather for the Lupus Foundation, it reminds me that, we really belong to each other. And the psychiatrist Carl Menninger, he said, if you see someone who is depressed, if you're feeling depressed, just go across to the railway track and find somebody who's in need and share and love them, and you'll feel better. It means that when we invest in each other, there's a glorious path for each of us. And as I welcome all persons in person here and those online, the board of directors for the Lupus Foundation, our volunteers, our survivors, our admin staff, and all those, the technical persons, and our sponsors, and I would just like to mention the sponsors up front: the National Health Fund, Wisinco, Co-Create, IPCA, Jamaica National, Flow Foundation, Auto Channel, Concept, TAC, Axel, Realism, Spa, Aesthetic, and Imagination. And to our special guests, we welcome you. I can see Dr. Webster Carr, who's representing the Minister of Health and Wellness. You may be seated. Right in this very university campus, on the 20th of June 1963, well, most of us were not born yet, right? The legendary Dr. Martin Luther King, in delivering the speech to the graduating class on the 20th of June 1963, and he spoke about his affection for Jamaica. And Dr. King said that we are inextricably linked to each other. We're inextricably linked as persons in humanity, and you cannot be what you ought to be if you don't help someone become what they ought to become. And I think central to the Lupus Foundation, it is that spirit, it's the essence, it's the ethos, where survivors, the doctors, the volunteers, the sponsors have incessantly come forward. And one great writer said that it's every man's obligation to put back into life at least the equivalent of that which you have taken out. And sometimes, we're going through all sorts of things. And we sit here this morning, many things on our mind. What I'm going to do next week, next year. And the late Oxford professor, C.S. Lewis, he said we might not be able to go back and change the beginning, but we can start today and change the ending. And today I'm saying, whatever you're going through in your life, personal, business, professional, family, that faith, that undiluted faith and passion that you walk by will carry you through. So again, welcome and good morning. I will just now ask our board member, Dr. Veronica Sells, to come and give us the opening prayer.
Good morning, sisters and brothers. And this good morning is for those who are online too. It's wonderful to be here this morning. And as I sat there waiting to come and lead us in prayer, my mind went back to years ago, in the last century, that is. 1999. And the Lupus Foundation has come a long way. And we give God thanks. So, let us join in prayer. We praise you, Lord. We praise you, Lord, for the provision over the years in our presidents, in the resource persons, in the support that we have received from sponsorship. We praise you, Lord. We thank you, Lord, that today we can be in person and online. It's wonderful. We thank you for all those who will make their presentations in one way or another. We love you, Lord. We love you for the gifts of people, including those of us who are challenged by lupus, because others reach out to those who are challenged to ensure that we are able to meet the challenges and to go forth. And so, Almighty God, healing God, providing God, generous God, we pray that today at this symposium you will guide us. You will guide us through those who will speak to us. You'll guide us through the questions. You'll guide us through our thoughts. You'll guide us through the material that has been provided. And finally, God, we surrender ourselves to you. Lord, we must confess that often we hear and we appreciate and we say, thank you, Lord. But Lord, we allow it to stop there. Lord, we surrender ourselves to you, all of us, challenged or those who support those who are challenged. Family members, friends, doctors, the hospitals, the clinics. Lord, we surrender ourselves to you to make use of the resources, and through these resources to ensure that the Lupus Foundation continues to lift up others. Lord, as we focus today on reproductive health and lupus, guide us and grant us your love, your peace to go forth. In Jesus' name we pray. Amen and amen.
Thank you, Reverend. Amen. Can I get an amen? Amen. I was just thinking, Rev, that there was this pastor on a Sunday morning, and he was preaching, and he got in the spirit, a small church, rural church. And he said, for those of you listening to me this morning, and if you want this church to creep, you start to give something consistently. And if you want to see this church walk, you start to give some more consistently. And if you want to see this church run, you even dig deeper in your pockets and give and give. And if you want to see the church fly, Oh my God, you go even deeper in your pockets. A little old lady at the back and say, no, Pastor, let it walk. So Sibla had the collection plate. And I was wondering if you're still going to pass it around since it's Sunday. But thank you very, very much. At this time, I'm going to invite our esteemed President, Desiree Toller-Reed, who hasn't slept from last week Sunday. So if you see her falling asleep, forgive her. I almost said president for life. Welcome, Doctor. Give her a round in. All right.
Master of Ceremonies, our special guest, Dr. Karen Webster Carr, representing Minister of Health, special invited guest, board members, friends, viewers, in-house and online participants. Good morning to you all. And we thank Mr. MacDonald, Mr. Cedric MacDonald, for his warm start to the program and kind introduction. The World Health Organization defines reproductive health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, in all matters relating to the reproductive system and to its functions and processes. Reproductive health implies that people are able to have a satisfying and safe sex life, and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. But with lupus, this is not always so simple. Lupus, unlike many other chronic or long-term illnesses, is a disease of the young, and with females involved 9 times more than males. Lupus may often strike at the peak of one's productive life, with implications for the individual, the family, and by extension, the community and wider society. Pregnancy can be a risky undertaking in a person with lupus, for the fetus, as well as for the mother. Sometimes there are medications not compatible with the pregnant state, leaving limited options. There are implications there around planning and navigating the reproductive process safely for mother and baby. We must tackle these issues as practitioners, how to plan, guide, and support this process competently and appropriately for the best outcomes. As patients and families, how to understand the issues and collaborate well with their care team. Pregnancy loss can also be a devastating experience for patients and families, and we must learn how to respond and prevent this. Certain medications, though not commonly used, may have implications for fertility. As we learn from our working definition, matters of reproductive health extend beyond the area of conception, pregnancy, and delivery. Our reproductive organs are an integral part of us that we carry for life, and we must preserve the health of these modest parts to preserve our health as a whole. As women of any age, men or children with lupus, or as the persons responsible for their care, what do we have to know or do to prevent or address disease or dysfunction, and to protect and preserve our sexual health, the ability to have, as the definition gives us, satisfying and safe sex life. We must ensure that persons are not defined by this condition, but are empowered to navigate life and to maintain relationships and enjoy sexuality, healthy sexuality, in spite of lupus. This is why we're here today. And we're grateful for persons who have given of their time and expertise to share the latest in knowledge and understanding of all these areas. Those that have made themselves available to share with us from their experience and to strengthen our depth of understanding, not only of the disease, but of the person as a whole, with plans and hopes and dreams and families and relationships. Lupus Foundation is dedicated to improve the outcomes and quality of life of those affected by lupus. Our symposium today, we believe, is part of our fulfillment of this mission. Thank you all.
Thank you, Dr. Tollereid. Is anyone celebrating a birthday today, by the way? Anybody celebrating a birthday this week? Could you stand for us? Can we just sing happy birthday? 1, 2, 2.5, 3. You can start as well. Happy birthday to you. Happy birthday to you. Happy birthday, dear. Happy birthday to you. May God bless you. And may you live as long as you want and not want as long as you live. Okay. I now invite Dr. Karen Webster Carr, Acting Chief Medical Officer in the Ministry of Health and Wellness, to officially open this symposium. Can I give her a big round of applause, please? Thank you.
Thank you, Mr. MacDonald. So I'll be reading a message of the Minister of Health and Wellness, Dr. the Honorable Christopher Tufton, on the opening of this lupus symposium. Organizers, distinguished guests, ladies and gentlemen all, good morning. My commendations to the Lupus Foundation of Jamaica on this year's staging of the Lupus Symposium. This year's theme of reproductive health and lupus is as important as it is timely. Lupus is a chronic or lifelong illness caused by a dysfunction of the immune system and which can be very expensive to treat. Jamaica is considered to have a high prevalence of the disease. What is more, lupus most commonly has its onset among young women, though individuals of any gender or age can be affected. Of course, the treatment and control of lupus has improved over the last several years, due in no small measure to earlier diagnosis and increased understanding of the disease. However, it remains a threat to life if the kidney or the brain become areas of major inflammation. I therefore urge those affected by the illness to carefully manage their lifestyle, including maintaining a balanced, low-fat diet and avoiding stressful situations, which could dangerously limit the recovery capacity of the body. The Ministry of Health and Wellness remains committed to the fight against lupus as we continue to provide specialist health care and essential drugs, free of cost, through the public care system, and subsidize the drugs available in the private system through the National Health Fund, an agency of the Ministry of Health and Wellness. We also have a hand in supporting initiatives that improve the awareness and understanding of the disease. I laud the work of the Lupus Foundation of Jamaica and other partners in the public and private sectors whose members individually and or collectively support Jamaicans living with lupus, including through their participation in this symposium. I have no doubt that this year's symposium will afford not only the chance for networking among stakeholders, but also that it will facilitate knowledge and experience sharing from which I trust insights will come concerning initiatives to better support Jamaicans living with this illness, including those of reproductive age. I look forward to those insights and wish you a most productive conference. It is my pleasure, therefore, to officially declare this conference open.
Thank you so much, Dr. Karen Webster Carr. At this time, I'm going to invite, okay, would just like to have a small presentation to you. Could you come forward? And I invite Dr. Raquel Lowe Jones to make the presentation.
Good morning, everyone. On behalf of the Lupus Foundation of Jamaica and our 2022 Symposium on Reproductive Health and Lupus, I would like to thank the Ministry of Health and Wellness for their continued support of the foundation, their continued support in and behind the scenes. And we're sorry that the minister himself couldn't be here this morning, however, but we do appreciate Dr. Webster Carr coming, and thank you again.
You want me? Okay. Okay. Thank you so much. I guarantee you won't be here until night. Right, Desiree? All right. May I just invite Dr. Tanisha McGee Phillips, consultant rheumatologist, Cornwall Regional Hospital, to take us through to the next segment. She's always smiling. Good morning.
Thank you very much, Master of Ceremonies. Good morning to everyone here in person. It's so good to see people in the flesh again in this symposium. That's amazing. And good morning to all our viewers online. Special good morning to our special guests. And of course, a big special good morning to our lupus warriors everywhere. It's so great to be here, and it is my pleasure to introduce our keynote speaker. So Dr. Klaus is a clinical rheumatologist with a long-standing research interest in understanding the real-world problems rheumatic diseases pose for our patients and identifying innovative approaches to solving these. She received her medical degree from Vanderbilt Medical School, followed by residency and fellowship at Johns Hopkins. She joined the Duke University faculty in 2005, where she is currently an associate professor in the Division of Rheumatology. Dr. Megan Klaus is an international leader in the study and management of rheumatic diseases in pregnancy, who has authored over 100 articles in peer-reviewed journals, numerous abstracts, chapters in books, and scientific reviews. She's a familiar face at scientific meetings all over the globe, sharing her expertise in this field, from matters of fertility preservation to the effect of lupus activity on pregnancy outcomes and everything in between. Our lupus warriors here with us today and online will be as excited as us clinicians to know that she has cared for over 900 pregnancies in women with rheumatic disease since initiating her prospective pregnancy registry in 2008. She's on the core leadership team for the American College of Rheumatology Reproductive Health Guidelines. And through quantitative and qualitative work, she identified gaps in rheumatologists' knowledge and communication skills as key drivers of poor pregnancy outcomes in women with lupus. To overcome this, she has created an in-clinic intervention and program to enable rheumatologists to provide effective pregnancy planning and management to women with lupus. Today, she will speak to us about lupus and pregnancy. Please do welcome her.
Thank you so much. And I so wish that I could be there with you today, not only because I would like to be in Jamaica, but also because I would love to meet all of you and learn from all of you. And clearly the whole person way that you address lupus and reproductive health is different than many places in the world, and I think much more complete and thorough and focused on patients than I often hear. So I hope someday to come and meet you in person. So today I'm going to talk about lupus and pregnancy. It is indeed my very favorite topic, and I am really pleased today to be able to share it with you. So my goals today are to identify ways that we can all together improve pregnancy outcomes for women living with lupus, that our clinicians in the room and online can learn about the one key question, and that we can all learn a tool to discuss contraception and pregnancy planning for women living with lupus. So systemic lupus erythematosus, often people call it SLE, I tend to call it lupus, is a systemic autoimmune disease. It can hit all different parts of the body, from the skin to the hearts to the kidneys. We can find things about it in the blood. It can affect the joints. As was said earlier, it is most commonly diagnosed in the reproductive years in young women. So between the ages of 15 and 44 is typically when it is diagnosed. And 90% of patients with lupus are women. In the United States, at least, Black patients have a higher risk of lupus. So we see it several times more often in our Black people in the United States. And when we look at outcomes for our patients, our Black patients often have more serious disease, more damage to their kidneys. It is typically treated by a rheumatologist, at least to some extent, because it is a complicated disease. And I think that particularly diagnosis by a rheumatologist is often very important. Most people have autoantibodies. The ANA is the most common antibody that we see in people with lupus. And basically everybody with lupus needs to have this positive at some point. But there's also other antibodies that can be positive. We use a lot of different medicines for this. Hydroxychloroquine, or sometimes called Plaquenil, is really our most commonly used medication. But we also use a lot of prednisone or steroids, and we use other immunosuppressant medications, which we're going to talk about in a bit. So lupus can impact a lot of different organs. And some of this is really obvious. So this is a patient, for example, with severe discoid lupus. These is a terrible rash, and you can see all of the pink on here is a really active rash. And this is unfortunately scarring. So this patient is never going to really grow her hair back, most likely, and will have these large scars on her body. So this is really this is our most serious and life-changing symptoms. We also can see damage to the joints and hands over time. Often hands in patients with lupus look pretty normal for a really long time until we get this kind of joint laxity where the joints kind of move around where they're not supposed to be. And then kidney involvement is also very common. This is a kidney biopsy showing a lot of inflammation on the inside of the kidney in a way that often shows up with protein in the urine. That's really our most common finding there. And lupus nephritis can be very serious and can lead to kidney failure, needing dialysis, a transplant, and so on. So we treat lupus nephritis aggressively with strong medicines. Sorry. So as I said, lupus is common in young women, and therefore preventing pregnancy when that's appropriate and pregnancy planning are really essential parts of lupus care. And a wide range of clinicians can really contribute to that. We know that lupus increases pregnancy risks because of multiple things. So that a patient with lupus has a lot of inflammation in her body makes a difference on the placenta. Her living with high blood pressure or hypertension, that also causes problems. Her having kidney disease also can cause problems. And then some of our medicines are problematic, and we're going to go over those in detail. So active lupus in the kidneys is really our most dangerous thing in pregnancy. So this is a meta-analysis, meaning a conglomeration of 3 different pregnancy registries in North America, mine, one at Johns Hopkins, and one up at the University of Toronto. And in these registries, what we can see is that, so we had almost 400 women with lupus who had a pregnancy. About a third of them were Black and about 2/3 were white. And what we can see is that active nephritis, that's the light blue bar, those patients really had the most problems in their outcomes. So 40% had a pregnancy loss, whereas everybody else had about a 10% pregnancy loss. Almost half of them delivered early, and about a third had preeclampsia, which is high blood pressure and protein in the urine that often leads to a very early delivery. When we look at patients with a history of lupus nephritis, so their lupus nephritis was inactive at the time of the pregnancy, you can see that they actually did about as well as the patients who never had lupus nephritis. So their fetal loss, for example, was almost identical. They had a little bit more preterm birth and a little more preeclampsia. One thing we saw in these studies is that our Black patients were more likely to have active lupus nephritis at the time of pregnancy, which led to more problematic outcomes for these women. So it's really important that patients and clinicians and doctors, everybody know that we can really impact and improve pregnancy outcomes. And the time to do that is before the patient is pregnant. So we know that taking medicines that cause birth defects, having highly active lupus at the time of conception, having low platelets, having high blood pressure, having untreated antiphospholipid syndrome, which is a syndrome that causes blood clots and pregnancy loss, not handling any of those before pregnancy, what we see is about a 40% chance of pregnancy loss. But all of these things can be managed ahead of time, and that decreases a woman's risk to closer to 20%. Preterm birth risk is about the same. So all these factors dramatically increase the risk of preterm birth up to 70% in some populations. But managing these ahead of time can really dramatically decrease a patient's risk. So it's really important to know that you can do something. These are not just inevitable outcomes, but doing so requires planning. There are a few other kind of issues that come up. So other than active lupus and medications that cause major birth defects, we also see that a woman with pulmonary hypertension, which is a pretty rare complication for lupus patients, but in which the blood pressures in her lungs are extraordinarily high, pregnancy is extremely dangerous for these patients, particularly after they deliver, with a very high rate of death in the mother. Similarly, a woman who's had a stroke or a heart attack is also at high risk for having these again during pregnancy, which is very risky for their health. So how do we help women avoid these catastrophic pregnancies and time their pregnancies well? And I think that the way to do this is to really facilitate conversations between the patient and any of her providers so that they can be very honest and accurate. When I say honest, what I mean is that the woman feels comfortable presenting sort of how she feels about pregnancy, whether she's trying to get pregnant, whether she's using her birth control or not. I've talked to a lot of different patients, and they've all told me that at some point they were dishonest with their rheumatologist about avoiding pregnancy. And that, and unfortunately for patients with lupus, can lead to catastrophe. So the patients need to be able to be honest, and that's on the clinician to set up an environment that the patient can be honest, but it also has to be accurate. So the doctor then needs to actually give the patient the right information. So taking all of the information I'm going to share with you and applying it to the patient herself. And only that way can we actually have collaboration. So how do we move towards these collaborative conversations? I think it can be a real challenge for certainly the rheumatologists in the US are not great at this. So I think the key is asking an open-ended question about pregnancy, about her interest in pregnancy, right? Definitely not assuming that she's not interested in pregnancy. A lot of our rheumatologists in the US do that. They assume that there's only certain times that a woman would want to get pregnant, and they think they can predict it, but they cannot predict those times very well. So this is what's called the one key question. The one key question is a well-studied and carefully created question, not for women with lupus specifically, but for women in general. And the question is, would you like to become pregnant in the next year? I think this is a great question. I actually often kind of extend the timeline. So it's, are you interested in becoming pregnant at any time in the next couple years? Or I sometimes say it in different ways. Are you thinking about having kids? Have your thoughts about having kids changed? Are you ready yet to have kids? You know, sort of, I use whatever is appropriate for the patient and what feels most comfortable to me. But asking this open-ended question has been shown that it increases the ability to do pregnancy planning as well as contraception planning because it allows these honest conversations. It's also really important that it's open-ended, right? So a lot of US doctors say, you're not planning on getting pregnant, right? Or you're using your birth control, right? Right? And those are not open-ended questions, right? Those only have one right answer to meet the expectations of the clinician. So it really needs to be an open-ended question. I have also found with some patients that they had assumed that I would never say it was okay to get pregnant, when it's actually quite fine for this patient to get pregnant. And so asking it this way has allowed some women to get into a conversation that they never would have brought up themselves and lead them to actually having a wanted pregnancy in the future. So it's really important that you start the conversation. And I think that that needs to be in the hands of the clinician whenever possible, because while some women will bring that up, a lot of them, in my experience, won't because they're afraid of what you're going to say. So when you ask somebody if they're interested in pregnancy, what it turns out, and this was a surprise to me, was that the women who are in the most risk for sort of things not going well from that point are the women who really aren't sure as to whether or not they want to get pregnant. So the I don't know, or, you know, sometimes you can tell as a clinician talking to a patient that she's like, oh no, but you can tell she actually, yes, right? Or she sort of asks in a way that, you know, asks back a question that shows that she's like sort of interested, but not really interested. So these are actually extraordinarily important conversations to have because these patients, in my experience, often don't end up taking the steps to get pregnant safely, but they're also not taking the steps to prevent pregnancy because they're kind of on the fence, right? They maybe think maybe they shouldn't get pregnant, but they kind of want to get pregnant. And so therefore they end up in this very high risk situation. And when we looked at these patients in our lupus population, what we saw was really this population of patients were the ones with the worst pregnancy outcomes. So we looked at the first 43 patients with lupus that we asked this to. 17 of them ended up having pregnancies that were not really planned. 26 of them had pregnancies that were pretty carefully planned. And you can see that the severe adverse pregnancy outcomes, these are things like the baby dying, a pregnancy loss after 12 weeks, and a very early delivery. You can see that all of them happened in our not planned pregnancies, and a lot of these pregnancies ended this way. You can also see that the babies had a long-term impact. So 70% of the babies that were born in these non-planned pregnancies had some sort of factor about them at birth that was going to likely lead them to long-term health problems. So I think it's really important, like the importance of planning pregnancy was not aware, I did not realize it, that this is really the thing that we need to do until I saw this data. So there are a couple of reasons that these unplanned pregnancies, I think, have particular problems. One is that women tended to get pregnant when their disease was more active, and we know that that leads to problems. But almost more importantly, I think, that medication plan was not established prior to them getting pregnant. So therefore, a lot of these women stopped pregnancy-safe medicines that they really should have continued to keep their lupus under control, but they stopped them because they didn't think that they should continue taking them. You know, certainly in the United States, the assumption is that you should not take medicines in pregnancy. And we really need to help women sort of overcome that barrier when they have lupus. In addition, you know, I had to start or restart a lupus-related medicine in every single one of these not planned pregnancies as a sign that like their lupus was more active, they were medicines that they didn't realize. Whereas when we look at our planned pregnancies, most women didn't stop medicines, and I only had to start them a new medicine in 30% of the pregnancies. So as a clinician, this is a challenge to all the clinicians who are here. I would love you to think about how you can make asking an open-ended question about pregnancy interest part of your just routine part of your visit. So I think it's worth practicing saying it because it sort of sometimes feels strange. I think that I really like the question, how would you feel if you got pregnant in the next year? Because that just even takes it away from the thinking process and can bring out some emotion, right? If a woman is like, oh my gosh, that would be terrifying, right? Well, that helps you sort of understand it. Or if she's like, well, I'll be kind of happy, but kind of worried, right? That's sort of this person who's in the middle ground. In a study, they showed that 20% of women of reproductive age changed their interest in pregnancy over the course of a year. So you really have to ask all the time. How can you do that? These are my suggestions to folks in the United States. Some people have intake surveys that patients do every time they show up in a clinic visit. I think that's a great place to put this. This is where we do it in our clinic. You could have whoever's checking in the patient, you could have them ask the question for you if the doctor is too busy and doesn't think of it all the time. You could put in your review of systems, right? So any chest pain, any shortness of breath, any stomach problems, any thoughts about kids in the next year or two, right? You can just sort of make it part of your routine. And I think that once women get used to it, they won't be surprised when you keep doing it every time. So that's how you start the conversation, but how do you actually get to an accurate conversation, right? So as a clinician, you actually need to know the things to say, but there's a lot, right? And I'm about to walk you through a couple of tools, I consider them discussion guides, that you can share with your patient and kind of use as a cheat sheet for both the clinician and the patient. So lupuspregnancy.org, I would love for you to head over there. You can use this QR code if you're good at that, but it is an easy one, lupuspregnancy.org, and you can see our website there, and it has lots of great information, and it's, I think, the easiest way to print out these handouts that I'm about to walk through. So you ask them if they are thinking about getting pregnant. They say no. You say, okay, how are you avoiding pregnancy? Sometimes you'll hear, I'm not really. Those patients with lupus need to be, discussed that they are quite fertile. I didn't say that before, but women with lupus almost always, in my experience, are quite fertile. They seem to fall pregnant almost easier than any of our other rheumatologic patients. unless they've received high doses of cyclophosphamide. Everybody else should not assume that they can't get pregnant. So then we're going to use our contraception discussion guide. So if you follow this link, you'll see where it should get you there exactly. And we're going to use this to have patient-centered decision-making. So it's really going to help the patient and the provider have good knowledge, and then the provider is going to help the patient make personalized choices by sort of walking her through the sheet. I don't consider this a handout that you can just hand to a patient and assume that she can just figure out exactly where she fits on it. If I could make that handout, I would. I just think that lupus is unfortunately more complicated than that. Okay, so this is what our handout looks like. And well, this is part of it. I had to cut it into two different sections. So step one here is that, and this is what the second page looks like, or the rest of the page looks like. So it has different classifications of sort of who can get which kind of contraception. So the way that you figure out where a woman fits on those classifications are here. So the main thing that matters is how active her lupus is and her risk for blood clots. The risk for blood clots in particular is the most important part here. So, does she have really active lupus? This doesn't mean really like arthritis and joints, moderate to mild skin disease. I don't count that in this category. It's really people with really active lupus nephritis or no platelets or CNS lupus, so internal organ involvement. Women who have a lot of protein in their urine, which actually increases their risk for blood clots. Women with antiphospholipid antibodies. So this is something that the clinician needs to help the woman understand whether or not she has these. They might need to be ordered at this point. But antiphospholipid antibodies are antibodies that increase the risk for blood clots as well as pregnancy loss. And then other things that make the woman high risk for blood clots outside of rheumatology. So whether she's had a blood clot or not for any reason puts her in this category. So you figure out sort of where she is on that risk profile. And then you walk her through sort of what the choices are. So not all contraception is equally effective. And for our women with lupus, I most strongly recommend highly effective contraception. And that is because of all the risks of pregnancy, of unplanned pregnancy we just talked about. So for women who do not want to have any more children, a tubal ligation or having her spouse have a vasectomy are terrific options because they don't have any impact on hormones. They're done. Certainly, however, if they're still thinking about having kids, this is not a good option for them. If they're interested in potentially having kids again in the future, but really don't want to get pregnant for the next couple of, for like a year or more, then in the United States, my favorites are the implant, which is just a single sort of rod. It's about the size of an inside of a Bic pen, about an inch and a half long, and they just stick it right under the skin. The providers do this, and then it just stays there for up to 3 years, maybe even longer, and it makes it nearly impossible to get pregnant until it is taken out by a provider. The IUD, or an intrauterine device, is a small little T-shaped device that goes into the uterus and just sits there and does its action. Some of them are copper and don't have any hormones. Some of them have progesterone. So the American College of Rheumatology guidelines say that all three of these choices, surgical, implant, and IUD, are safe for all women with lupus. It doesn't matter if they have active lupus. It doesn't matter if they are on immunosuppression. It does not matter if they have a risk for blood clots. All of these things are considered safe for women with rheumatic disease. Effective options are typically hormones. So these are medications that have hormones and that need to be used on some sort of a regular basis. So the Depo-Provera shot is every 12-week injection. There's pills with estrogen. When people talk about birth control pills, they typically mean birth control pills that have estrogen in them. There's a ring that has estrogen and progesterone. There's a patch that has both. And then there's the mini pill, which is I don't know if that's a US term, but it's a progesterone only pill. So these are pills that don't have any estrogen in them. So the main predictor of what the woman is safe for is based on her blood clot risk. So if she has a risk for blood clots, then she should not get estrogen, because we know that that increases blood clots. And there's some data that Depo-Provera, the progesterone-only shot, might not be a good idea as well. If she has really active internal organ disease from her lupus, we also do not recommend estrogen. And then we don't typically recommend the patch for any women with lupus because it has really high levels of estrogen. So these are recommendations. If you have a patient who's might have increased risk for blood clots, but really the Depo-Provera is the only thing that seems to be acceptable and working and so on, then that doesn't mean that she can't use it. These are simply recommendations. Then we have what I like to call our ineffective birth control, or sort of least effective. These are all things that have to be used during sex. And that, you know, is problematic for some people. So some of these, particularly the condoms, the man has to do. Other things like the diaphragm and spermicide, the woman has control over and needs to put them inside her vagina before she has sex in order to be effective. So these are things that are helpful, but only if you use them every single time. And even if you use them every single time, they're still not 100% effective. And that's because there are millions of sperm, and it's just not surprising that, you know, a couple can sneak around and get in and cause a pregnancy. I think of these as most useful when we combine them. So we combine sort of one of these barrier methods, we like to call them, or the less effective, with one of our hormonal contraceptions. So say you have 100 women who are using the mini pill, maybe 9 of them would get pregnant over the course of a year. And that seems a little high for me. However, if they're all using condoms, then actually only maybe 1 of them would get pregnant. So it definitely can be additive, particularly if a woman is not being 100% on using her hormonal contraception. She knows she misses pills, then she really needs to use barrier methods. There is also on the handout information about emergency contraception, which in the United States is typically called Plan B and is available over the counter without a prescription, as well as from Amazon. And I strongly recommend that women actually just purchase this ahead of time when they don't need it. It can be taken within 3 days of unprotected sex and will dramatically decrease the risk of getting pregnant. It is different from the abortion pill. It does not cause an abortion. It is simply progesterone, which is a hormone that is in huge supply early in pregnancy. So it will not terminate a pregnancy. What it does is actually just keep the egg and sperm apart so that they can't swim towards each other and cause, create an embryo. So emergency contraception is a great idea for women to just pick up ahead of time. So if they're on something that's not highly effective, I think it's a great idea for them to have it at home. So that's the end of the contraception part. And let's move on to the planning of pregnancy, because that's so important. We have a lot of information about this on the website, and we're going to walk through the discussion guide for that. Okay, so you have a patient. She's interested in getting pregnant. If you want to use the QR code, it will get you to the handout right now on your phone. She's potentially interested in pregnancy. Either she's like, really, like, yes, we're ready to go, or she's kind of in that, like, not really interested yet, but I might be in the future. I think this is a great time to go through this handout, at least in a skeleton form, so that the woman has some idea of what's coming. And certainly those women who are like very much on the fence, I think this is a great way to go through the information with them as well. So as you can see, the handout is numbered. So it has like 1, 2, 3, 4. And I personally go in that exact order. I use this handout actually all the time, like multiple times a week. So I start with number 1. And that is the key point that I want everybody to be on track with. And that is that we see more pregnancy loss and more premature births when somebody gets pregnant when her lupus is active, or she is taking some of our stop lists, which are our teratogenic medications, medicines that cause birth defects. And the way to have the safest pregnancy possible is to take medicines that are on our go list or our safe list, and to keep the lupus activity as quiet as possible. All right? So women need to know that they actually have some control over how things go. And that's by taking medicines to keep their lupus under good control. In my experience, almost none of my lupus patients are able to be off all medicines for a safe pregnancy. I'll add to that point that some of them try. So I certainly have patients who do not take their medicines despite prescribing them. And when we look at drug levels, for example, of hydroxychloroquine or azathioprine, when they're very low, such that they're not taking the medicine, we often see more early deliveries and pregnancy loss. So question number 2 is your lupus well controlled? The clinician needs to help the patient figure this out. Often what we see in the United States is that the symptoms that cause the most problematic things in pregnancy, in particular lupus nephritis and really low platelets and hypertension for that matter, often don't actually cause physical symptoms. So some of our patients with active inflammation in their kidneys don't really know how sick they are because they feel okay. And so that must mean that they're pretty healthy. That is a very common misconception, unfortunately, in the United States, and it leads to a lot of our dilemmas, I think. On the other hand, we have a lot of patients who are really pretty achy, tired, mild rashes. And in my experience, those symptoms actually really don't negatively impact pregnancies. And so some patients will assume that because they feel poorly, they think it's really unsafe for them to ever have a baby. And that is something that's also a really important misconception to help women understand that that's not true, that they could actually potentially have a very healthy pregnancy. We'd like to have people not flare in the 6 months prior to conception, and I count that as needing an increase in prednisone in the prior 6 months. And then this is a good time when we're having this conversation to check some specific antibodies that are important in pregnancy, and we'll talk about those soon. So in terms of medicines, the key to this discussion guide is the answers are on the page, all right? I don't expect clinicians or patients to remember which medicines are safe for pregnancy or not safe for pregnancy, because you all have plenty of other things that you need to remember that you do more than pregnancy. So the answers are on this discussion guide. So that's why I really strongly encourage you in your clinic to print it out, tack it up on the wall so that you have it when you need it, and use the list to be able to give the woman accurate information. So first step, continue or start our good medications. I'm going to show you those in a second. Hydroxychloroquine is recommended for all women with lupus who don't have any major contraindications to it. So if you've had a big, horrible, terrible allergic rash to it, then you don't get it in pregnancy. But most everybody else, our recommendation is that you take it during pregnancy. If a patient is taking any stop list medicines, then we have them switch over to the safer medicines. And if she needs to be on at least 5 milligrams of prednisone a day, or especially if she's sort of going up and down on her prednisone dose to keep her lupus under good control, then we recommend increasing or adding one of our safe medicines. So here's the medicines. So our pregnancy compatible medicines, or our GO list, include a wide range of drugs. So hydroxychloroquine, as I already talked about. If you can only tolerate chloroquine and not hydroxychloroquine, that's okay in pregnancy too. Azathioprine or Imuran is really my #1 immunosuppressant for patients with lupus in pregnancy. Up to 20% of my patients are on it during pregnancy. And it has been shown to be safe from decades of use during pregnancies in patients with lupus nephritis. Colchicine can be used, cyclosporin or tacrolimus are kind of second line ones that we use for people, particularly with lupus nephritis. And then prednisone, it is on the pregnancy compatible list, but it's probably our most dangerous one on the pregnancy compatible list. So I use it sparingly. I use it when we need it. So if somebody shows up with big, very active lupus nephritis, she needs prednisone. If she's living with some achy fatigue and a little bit of rash, then I try to minimize the prednisone. We also have medicines that are on the stop list. So those are medicines that we know cause major birth defects. So the one that most clinicians know right off the top of their head is methotrexate. It does cause major birth defects in about 6% of exposed pregnancies, but it also increases pregnancy loss to about 40%. So we like to stop that at least a month before pregnancy. Mycophenolate or Cellcept is probably our most risky medicine in patients with lupus Similarly, mycophenolic acid, which is a cousin of mycophenolate, is also really probably quite problematic. So this is a medicine we use for lupus nephritis. So a lot of our young women are taking it. It also causes about 40% pregnancy loss, but of those surviving pregnancies, 1 out of 4 will have a major birth defect, and is most common a facial abnormality or a major ear defect. So these are tragic, complications for families, for mothers, for babies. And so it's really important that women who are taking mycophenolate, which will save their kidneys, are planning to avoid getting pregnant. Cyclophosphamide does cause ovarian failure, but it also causes major birth defects. So women who are receiving this, which is less common, should be on effective contraception, and before any infusion is given of it, a pregnancy test should be done. And then thalidomide and lenalidomide we don't use as much, but definitely cause major birth defects. Leflunomide or Arava is a medicine we don't use a lot for lupus, but we use it more for arthritis. It causes a lot of birth defects in rodents, but really actually very rarely in human beings. So we don't recommend continuing it. We definitely recommend stopping it ahead of time if possible, or as soon as possible. And then we give cholestyramine to wash it out. So if a patient gets pregnant on any of these medicines, we recommend she stop it immediately and call her doctors. The calling the doctor is important, because if a woman needs one of these medicines to control her lupus, then we strongly recommend she get switched to azathioprine, all right? Because we know that stopping mycophenolate in a patient with lupus nephritis will just make her lupus nephritis worse. And so just hoping for the best, in my experience, is not a great strategy. So anybody who gets pregnant on mycophenolate, I almost always switch them to azathioprine immediately. There's a couple of newer medicines. There's 2 more on here in the United States, anifrolumab and voclosporin. We don't have complete information about safety for these. So this is very much a risk-benefit balance. And I'm always happy to answer emails or have phone calls to help weigh out the situation for some of our patients. But particularly because some of these medicines seem to help lupus nephritis, and we know how terrible lupus nephritis is to a pregnancy, I'm beginning to think that the potential hazards of these medicines probably are not nearly as serious as lupus nephritis itself. So other things, aspirin, we recommend low-dose aspirin. We have 81 milligrams tablets. I don't know what your tablets are, but whatever your low-dose aspirin is that you use for heart disease and so on, would be 1 tablet every day, starting sometime in the first trimester. And then I don't make rheumatologists answer any other medications for pregnancy, but obstetricians are particularly good at that. So which doctors need to be involved? I think that everybody with lupus should see a rheumatologist every trimester at least to help really assess her disease activity, because certainly in the United States, our obstetricians and high-risk obstetricians just don't have the skill set. Just like you don't want me delivering your baby. That's not my skill set at all, but rheumatologists are the best folks to help decide how active lupus is. In the United States, I recommend that everybody see a maternal fetal medicine specialist. That's a high-risk obstetrician. I think that in the United States, our local obstetricians are great at sort of routine monitoring, but often have not seen patients with lupus. So some of these patients really probably need to go to sort of as specialized center as possible, particularly those with lupus nephritis. And then any other doctors that happen to be involved in the patient's care, it's a good idea to get them involved. A few last kind of things. So antiphospholipid syndrome, as I said, it's when you have antiphospholipid antibodies and you have increased pregnancy loss and or blood clots. All of these patients should be on low-dose aspirin, and then also should be on heparin shots every day during pregnancy. And the dose of that heparin depends on whether she's had a blood clot or not. If she's had a blood clot, then she needs to be on a higher dose. Rho or SSA antibodies are found in about half of our patients with lupus and many, many more in our patients with Sjogren's syndrome. These antibodies cross the placenta, and in about 1 out of 100 patients can cause a permanently slow heartbeat that's called congenital heart block or neonatal lupus. So fortunately, data has shown that hydroxychloroquine can cut that risk in about half. So anybody with a Rho or SSA antibody, I typically recommend that they take 400 milligrams of hydroxychloroquine throughout pregnancy, ideally starting ahead of pregnancy. We also in the United States often do echocardiograms of the baby's heart throughout the second trimester to look for any changes that might suggest changes in the rhythm. As I said, high blood pressure needs to be carefully monitored and controlled. In the United States, our obstetricians and maternal fetal medicine doctors are great at this, and to be honest, better than our rheumatologists. The only caveat there is that we don't want patients taking an ACE inhibitor like lisinopril or an angiotensin receptor blocker, because those are known to cause birth defects, particularly in the second and third trimesters. And then pain, interestingly, I actually see less pain in our lupus patients during pregnancy. Often the achy fatigue of lupus gets better in pregnancy, which I think is fascinating. In the United States, we usually rely on acetaminophen in pregnancy and don't use a lot of NSAIDs like ibuprofen. That seems to be, as best I can tell, somewhat regionally based. So I think that rheumatologists don't necessarily need to answer the pain management questions, but our obstetricians are usually better at that. So in summary, sort of my take-home points, the key to successful rheumatic pregnancy is timing, right? And that takes planning, all right? So we can't just assume that our patients are gonna just fall pregnant at the right moment. Every once in a while that happens, but in my experience, more likely when they fall pregnant without planning, they stop their medicines and their disease is active because of that, or it was active anyway. So I suggest that you routinely start open and honest conversations with open-ended questions about pregnancy, and you figure out a place to put that into your visits. And then I would love to have you try the lupuspregnancy.org handouts and website. I would love your feedback. If there's changes that you would suggest so that it works better in your country, I would love to hear what those are. And maybe we can sort of revamp it a little bit for you. But all of this together, in my experience, really can help us get to the joint goal of every woman with lupus having her safest pregnancy possible. Thank you so much, and I am really looking forward to questions.
Thank you so much, Dr. Klaus. That was truly a very important talk that we needed to have, because you've provided us with a wealth of information and practical tips to have that collaborative conversation and practical tools that will not only help us to deliver accurate information, but also to do so efficiently. Our clinics are often overwhelmed, and many of us supervise juniors, and to have a resource that everyone can be on the same page is really, 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 really a lifesaver for us who really do have a lot on our hands in our clinics, especially in the public system. So we thank you so much. You know, when we as a group sat together and we decided that this was the area that we're going to cover, and we thought about who would be the person who would do the best justice to this topic. Your name and only your name came up. So we thank you so much. And it's a pity you couldn't be here with us to feel the warmth of our weather and the warmth of our people. But thank you. Another round of applause for Dr. Klaus, please. So just to tell our viewers online, we are taking your questions in the question and answer, the Q&A box at the bottom of your Zoom, on the Zoom platform. Now, the chat is also taking questions now, we understand, but if we run out of time, the questions in the Q&A box will still be there that we can even field to Dr. Klaus later on to get the answers to those. Mm-hmm. And to those who are on YouTube and Facebook, we're trying to get your questions to us as well to be answered. So send your questions to us, and if they don't get answered now, we will try to get them answered later. So just a reminder, the Q&A box to have your questions sent to us. Now, Dr. Klaus, I'm going to start off with the question about accuracies. As clinicians, we want to make sure that we're always accurate. What is perhaps you think the most prevalent inaccurate information provided in your research thus far?
Yeah, so that's a great question. And in the United States where I am, the most problematic bit of advice that I think is often wrong is about which medicines are safe to continue in pregnancy. So fortunately, I don't see it as often in the US now that obstetricians or primary care doctors will tell women to stop hydroxychloroquine. That one, I think everybody is kind of catching on with. Not quite everybody, but that one's catching on. But I still have some arguments with azathioprine in particular. You know, the FDA used to use sort of a ABCDX guide for what was safe in pregnancy, and they stopped using that 5 or 6 years ago at least because it was not accurate. And it is not accurate for azathioprine. It lists it as D, which suggests that it wouldn't be safe in pregnancy. However, it is by far our safest option for our patients. And so I still get arguments, sometimes even within my own institution, that, you know, a dermatologist has, you know, doesn't know anything about azathioprine and looked it up on some website and tells a patient, oh no, you can't take that. I see that from high-risk obstetricians at other places. I definitely see it from primary care doctors or regular risk obstetricians who just aren't comfortable. So when you look online, you aren't necessarily getting the most accurate information. So the place I most strongly recommend you go if you have questions are the American College of Rheumatology's reproductive health guidelines. They came out about 2 years ago. It's very up-to-date information, and that's where I would go for medication safety.
Thank you, Dr. Klaus. Now, on the other end of this collaborative conversation that we need to have, so we talk about, you know, as us clinicians, the accuracy, and for our patients, honesty. And looking on the patient side, do you have any kind of hints as to which of our patients, how do we pick up that 20% that's likely to change their mind in that first year? Any hints, anything in the conversation or anything that you kind of have gleaned over the years?
That's a good question. I don't really know. I think that certainly in, you know, somebody who's getting married or sort of finishing school or sort of making a transition that way, but certainly, you know, boyfriends come and go, it seems, and they don't always share that with their doctor, particularly in a quick visit. So I have not seen, you know, really clear predictors. When we looked at our population, about 16% at any one visit said that they were interested in pregnancy. It did not go by demographics. It was only women of reproductive age, and it didn't really go by whether they were married a whole lot. So a lot of our unmarried women, about 10% of our unmarried women were interested in pregnancy, did not go with disease activity. A full third of our patients who were interested in pregnancy had really active lupus or were taking mycophenolate. So, you know, it's not like just when you think they're medically ready that's the time to talk. It's really much more often than that. You could probably sort of guesstimate with, you know, what they said last time, but I wouldn't hold them to that.
Okay. And now we have a lot of nephrologists in our group, and we do collaborate extensively. So I have a question for you in terms of lupus nephritis. Sometimes we see random creatinine values saying that, you know, someone should be advised against pregnancy if their creatinine is this value. Do you have any cutoff values? Is that a thing?
Mm-hmm. So, I don't see that on labs, but I definitely would say that so one thing is that creatinine tends to go down in pregnancy. So a normal creatinine outside of pregnancy is a little bit higher than inside of pregnancy. Interestingly, in my experience, it really is poor pregnancy outcomes are more driven by the amount of protein in the urine and sort of the background inflammation from lupus as opposed to the creatinine. So, you know, if a creatinine is like twice normal, that would probably begin to make me nervous, but even more nervous based on how much inflammation she has in her kidney or how much protein in the urine. So I have seen some pregnancies in women with pretty high creatinines that went well as long as they didn't actually have lupus in their kidney. So I think it's really the presence of lupus nephritis and particularly active lupus nephritis that is the biggest worry.
Thank you so much for that. I'm going to ask you a difficult question that I think it's a question that a few of us have had to try to navigate. So now our patient who is on a stop drug is pregnant. That's a very difficult conversation to have. Help us navigate that.
Absolutely. So we actually have a place on the website that goes over that specifically. has a lot of information there. So in this situation, I would go there if you need numbers. But here's how I typically address it. So because I see this not that infrequently, because everybody sends these people to me from across the state. So first, as a clinician, it's worthwhile to like check your emotions and make sure that you're being really empathetic to the patient, because though it is hard for you as a clinician to handle it, it's probably harder for the patient, right? Who is suddenly in this really potentially dangerous situation that she has kind of created for herself. And so kindness and empathy, I think, is really important. Yelling at patients, not helpful, right? Next is have her stop the risky medicine immediately. So have her stop for mycophenolate or stop for methotrexate. I recommend that most people see an obstetrician or a high-risk obstetrician pretty quickly. This is sometimes a phone call to them to get the patient in quickly, because obstetricians and high-risk obstetricians are much more comfortable and used to this situation, because there's a lot of medicines that can cause birth defects. So they are often better at these conversations than the rheumatologist. But the rheumatologist, I think, should take sort of a couple of approaches. So one is making sure that the woman has accurate information about what the risks really are. So I have that on the website, but basically for methotrexate or mycophenolate or a cyclophosphamide, it's about a 40% risk of major pregnancy loss. So that's pretty high, right? So the general population is probably about 15%. So now she's at about a 40% risk of pregnancy loss. And that's not necessarily only early pregnancy loss. Sometimes we see it later. And then for methotrexate, she's at less than 10% risk for a major birth defect. For mycophenolate and cyclophosphamide, she's about 1 in 4, so about 25% risk for major birth defects. So that's a much bigger risk. And then, so I think it's important that she have that, really understand that. And sometimes you have to sort of talk through it a few times. And that's what I think obstetricians are particularly better at sometimes than our rheumatologists. And then, you know, in the United States, well, our access to pregnancy termination and abortion is variable now based on your state. But for patients who've conceived on mycophenolate or cyclophosphamide, the way I typically say this is some women in this situation would choose to end this pregnancy. Is that something you might be interested in? So I have learned not to recommend pregnancy termination, because that is a very personal decision for a woman. And it also, in my experience, really ends up making an adversarial conversation and relationship between the patient and the doctor that does not help anybody in the pregnancy. So I think at least sussing out sort of how interested, like where's the patient on this? Because often it's an unplanned pregnancy, so it might be also an unwanted pregnancy. So that's how I handle it. And then I switch her to safe medicines right away. The azathioprine, make sure she's taking the hydroxychloroquine. She might need to start on some prednisone. So that's really how I handle that.
Thank you for that. Dr. Lauren Fisher is with us, and she's one of our nephrologists, and she'll be fielding you some questions from the live chat. Laurie?
Excellent. I can't hear you.
So Dr. Klaus, while Laurie is getting her questions together, what's the feedback that you've gotten from these tools in terms of, you know, taking it outside into the community? What's the feedback like from clinicians?
Yeah. So I think that patients find it helpful. I usually encourage them to take it to their other doctor's appointments. So take it to their primary care doctor or their obstetrician to ensure that everybody can be on the same page. I think it will help bring along clinicians who don't know as much about lupus to be like, oh, I see azathioprine is a safe medicine. Right. And oh, you're not supposed to be on the mycophenolate. So I think it's helpful in that way. I think it's always worth pointing out, you know, at the bottom it says, and it is aligned with the American College of Rheumatology's reproductive health guidelines. So it's not just stuff that I, you know, made up. It is guideline approved. And so I think that also helps. But I usually get very good feedback from people. We actually just got a large grant from the National Institutes of Health, in which we're going to actually test it out in Chicago in a very underserved clinic population. So I'm really interested to see how it works on kind of a broader population level.
Congratulations on that. Yes. So Laurie,
I think my
Laurie?
mic is working now.
Yes.
Can you hear me?
Yeah, okay, so yes. So.
Okay, so my two questions are actually from two clinical experiences. So one question was, as a nephrologist, clearly I'm going to see the patients who are higher risk. By the time they come to me, most likely they're going to need a biopsy and have active lupus nephritis. So one question actually came from one of my patients who had significantly active class 4 disease, but just got married and wanted children in the future. And she's 35, right? So she was asking me about egg harvesting, which I wasn't quite sure about. How do you advise that? Because, what I told her was, you're disease active. I have to treat you. The best treatment here would be CellCept right now, and getting you into remission first before you get pregnant. But her concerns were like, I'm 35. When is that going to be? So that was one question.
Can I answer that first?
Yeah, sure.
Okay, so because otherwise I can't remember them. So that's a great question, right? So we know that cyclophosphamide, which could be an option for treating her, will likely cause ovarian failure and make her infertile if she's already 35 years old. If you give cyclophosphamide to like an 18-year-old woman, she has a much better chance of having babies in the future. But a 35-year-old woman getting cyclophosphamide would likely be unable to get pregnant. Mycophenolate does not impact fertility specifically. It would just make it, obviously, as we just talked about, dangerous, right? And we would probably recommend, depending on how bad her nephritis is and how quickly it gets under control, that she's really not going to be able to get pregnant for a good year, maybe 2, maybe 3, right? And then she's, much older. So egg harvesting is a reasonable approach. So to do egg harvesting, what happens is you have to do basically a cycle of in vitro fertilization. So the woman is given injections of hormones that make her make a whole bunch of eggs all at once. And then the reproductive endocrinologists go in and with a needle through the vagina and extract the eggs and then freeze them. Often they mix them with her husband's sperm and make embryos and freeze those. But also sometimes they actually, if you don't have a partner and you're doing this, they can actually just freeze the eggs and then defrost them later and mix them with sperm. So egg harvesting, I think, is a great option in this sort of situation. Our main concern is that it's going to suddenly drive up her estrogen level, because usual IVF drives up estrogen levels pretty high, which puts her at risk for blood clots, puts her at risk for increasing lupus activity. I think there's actually three ways around this. So there are some protocols that the IVF doctors can look up themselves, because I don't know exactly how to do it, that have been tested in women with breast cancer. So there's a lot of women who have breast cancer, like a young woman with breast cancer will often have surgery in the United States, and then 6 weeks later, she'll start chemotherapy. And during that 6 weeks, they'll harvest eggs. So they have protocols that don't drive up her estrogen so high. So that's one good option. Number two is that you just manage her risk for increased lupus activity with more prednisone that month, which I find acceptable in the, with the sort of importance of this moment. Similarly, if she's at increased risk for blood clots, she can be on full dose anticoagulation. She'll have to hold it right around the time that the eggs are harvested so she doesn't have bleeding. But that also, given the importance of this issue, I think could be potentially managed. So we don't typically do it while a woman has super active lupus if we can avoid it. But I personally think that being a mom is really important. And so I think that working with women in those kind of rare situations is very much worthwhile.
Thank you. Thank you. You guys can still hear me, right? Okay. The second question has to do with kind of when you have a patient that will get pregnant or who wants to get pregnant. For my, it was actually a patient who had lupus nephritis, but she had quite significant scar in her kidney, so she has residual CKD with some proteinuria, despite being kind of stable. And she gets pregnant. Is there a role, I mean, what was useful for us was multidisciplinary kind of approach with maternal fetal medicine, eventually later in the trimester, later trimesters, neonatology. Do you guys have multi-D clinics for those high-risk people, like my patient who just ended up getting pregnant and was a high-risk pregnancy? And was that beneficial? Did that change outcomes?
Yeah, that's a great question. So very, very few places in the United States have really effective multidisciplinary clinics in this situation. There still is not a lot of people like me who are reproductive rheumatologists. You know, I work in a sort of multidisciplinary group, not all in one location, but, you know, I have the folks in high-risk OB know me better than anybody else. It's like the one place that I get to walk in and everybody's like, oh, Dr. Klaus is here, right? It's the only place in the world that happens. And so I work very closely with my maternal fetal medicine doctors and my nephrologists in order to get through these really challenging pregnancies. So in my experience, a lot of patients who are sort of in that circumstance will want to stay pregnant. I think that in North Carolina, I would certainly justify a pregnancy termination in that situation if that's what the woman wants. But in my experience, a lot of people don't. And so we hold hands, we pray a little bit, to be quite honest, and we hope for the best, and we treat as aggressively as we feel is safe. So controlling her blood pressure really carefully is important. We don't want it too low, because if it's too low, then you don't actually give blood to the placenta, and that's a problem. But you certainly don't want it too high. So we like it to sort of be like just under 140/90 kind of range. We you know, optimize her lupus medicines as much as possible. We work with her to make sure she's taking them and there's not barriers to her taking those medicines. And then we all see her really often. The maternal fetal medicine team tends to do more ultrasounds, particularly once you get past about 22 weeks, 24 weeks, they'll do more ultrasounds to look if the baby's growing okay, you know, because those ultrasounds really help them understand how well the placenta is working. And in my experience, often these patients will deliver early. My goal is getting them past 28, 30 weeks, and I consider a 32-week baby in that kind of situation a clear success. Because, you know, this is a patient, right, with kidney scarring. She's never going to be able to have a, like, healthy, normal pregnancy. It's just not feasible for her body to do that. And so my goal is that we get her the healthiest pregnancy and the healthiest baby possible. And that for all women is not, you know, delivery at term that's easy, right? That's just not for our patients with lupus, and that's their reality. I used to, and I think a lot of rheumatologists still sort of say, well, that person should never get pregnant. But doing so means that she will never be a mother. And as a mother of two, and having taken care of so many women, that is a huge toll that lupus has to take on women, to say you can't be a mother. That is just not acceptable to me in almost any situation. So these women, you know, I think it's important that we honor their desire to be a mother, that they go into these pregnancies with as much information and eyes wide open as possible. And then we just hold hands and do the best we can to get them through them.
Thank you.
Thank you so
Thank
much.
you.
Thank you, Dr. Klaus. I mean, we could go on and on and on. This has been a wealth of information, and we really do want to thank you as clinicians for empowering us to have the right conversations. And I speak for our patients. We thank you for enlightening and empowering them with this knowledge. And we thank you for the practical tools that we will use. And just to point everyone to lupuspregnancy.org, and we have lots of our obstetricians online too who are excited and looking forward to this talk. So this is beyond just us as rheumatologists, and we hope to have you here one day in the future in Jamaica.
I hope to as well. I will say on the website there's actually a handout made specifically for OBGYNs. I worked with my OBGYN colleagues, so just hunt a little bit more on the website, and there's a specific discussion guide that has sort of stuff about like pregnancy monitoring that the OBGYNs might want to use instead.
Awesome. Thank you so much. Thank you. All the very best with all of what you're doing, and we really do appreciate you taking the time to share with us. All the very best, Dr. Klaus. Thank you.
Perfect. Thank you so much.
Thanks again, Drs. Klaus and Dr. Tanisha McGee Phillips for so ably moderating this session. Thank you very much. I'd just like to again to mention our sponsors: National Health Fund, Wisynco, Co-Create, IPCA, Jamaica National, Flow Foundation, Outer Channel, Concepts, TC Printers, Axel, Realism, Spa Aesthetic, and Imagination. Pardon me? Ophthalmic Suite in the Musgrave Professional Center, right? Thank you very much. So very kind of you to, some of you for many years have been assisting us, and we do appreciate it. Is there anyone visiting from out of town? Any doctors or attendees? Could you all stand? Oh, those ladies, I think you're from Mandeville. Wow! Yay! Maypen. Hey, Maypen. Big up Maypen. Oh boy, I see Dr. Malin Melody over there. Hi, Dr. Malin. Our association goes back to about 1986, right? You know, I'm very grateful that for the last 2 decades, I've attended so many of these sessions, MAJ. Recently, I saw Dr. Tanisha McGee at the consultant banquet, and I saw her at the Pegasus at the symposium. I'm seeing her today. I will book you up next week again. Thank you very much. And we're coming up to Dr. Lori Fisher soon. When her name is mentioned, I mention her name to somebody. Say, "Oh, she's so smart." Anyway, at this time, I would like to invite Charmaine, Mrs. Charmaine Rabotham, who will speak to us, and she's representing the National Health Fund. Yeah.
Thank you very much, Mr. McDonald. Let me begin by expressing congratulations to Dr. Denise Toller-Reed and her team at the Lupus Foundation of Jamaica for successfully hosting this event for the last few years. The NHF has consistently provided sponsorship for this conference. And we're proud of the partnership with the Lupus Foundation because as a healthcare organization, we place great value on partnership, and we really need this collaboration in the delivery of healthcare in Jamaica. So let me get through my presentation quickly. I have 5 minutes. The NHF support for lupus. Okay, it's not going forward. Can you go to the next slide? Okay. So the NHF is an agency of the Ministry of Health and Wellness, as was mentioned earlier. The fund provides affordable and accessible medication for Jamaicans through one, the Individual Benefits Program, which you may know as the NHF card, but we also manage the delivery of public health sector pharmacy services through the DrugServe program. The NHF card, and that there is the new design, there are several benefits on the NHF card. Of course, there are the prescription drugs which are covered, but we also cover respiratory devices, diabetic supplies, diagnostic tests. There's double subsidy for children. So persons who are on the NHF card program who are 19 years and younger, they get double subsidy. So whatever the adults get, they get twice that, but never more than 95% of the cost of the drug at the pharmacy. That 5% will either come out of pocket or from the other health card that may be used. And of course, it can be combined with private insurance. There are 17 conditions covered by the NHF card, and as you see here, lupus is one of them. Lupus was added in 2019. There are, oh Lord, Okay, so there are 18 active ingredients that are commonly prescribed by physicians that are on the NHF card program. Now, in looking at the subsidy rate, on average, the subsidy rate for medication using the NHF card is 43%. But we do have some medication where the subsidy goes up to about 70% of the cost of the drug. There are 7 conditions who have rates exceeding 50% of the cost. They are prostate cancer, breast cancer, high cholesterol, psychosis, and of course, lupus. Lupus had the second highest average subsidy per claim of $17,301. And for last year too, we paid out some $13.5 million in subsidy for the treatment of lupus. When lupus was started, we heard that there were 6,000 patients in Jamaica estimated with lupus. However, to date, the number of persons enrolled on the program is only 1,389 at the end of October this year. So it's very important that we continue the education, and we ask all of our physicians to ensure that if a patient comes to you that has lupus, that you get them enrolled for the NHF card. Of course, perhaps one of the reasons for this is that perhaps many patients are seen in the public sector, and therefore they get their medication free of cost. But it is possible that there may be an item that is not on the VEN list, which is the government-free medication, right? And therefore, if they have the NHF card and it's on the NHF card program, they can get the discount for the medication. Now, just to note that the NHF merged with the JADEP card in 2020, so we're not issuing the JADEP card anymore. How to apply? It's very easy. The patient can download the form from the website, or they can, get a form from the doctor or pharmacy or from the NHF drug serves or card centers across the island. We have 21 of them, and they fill that out and take that into us. There are some doctors that can actually register the patient right there in their office, because we have an online platform for doctors only, because doctors are the only ones who can certify a condition. So it's not something you can, sign up on the website, because if the doctor doesn't sign it, you won't get an NHF card. So we have this online platform for doctors only, so that they can sign persons up. And as I noted earlier, the NHF manages the drugstore pharmacies, which is the pharmacy services for the public sector. So for patients who are getting their lupus medication via the public sector, there are different means that they can use to get their prescription quickly without having to wait for the average of an hour, which it takes to get your medication. They can use a scheduled refill, which means if you're getting medication every month, you're put on a program where we call you to say your medication is ready. You sign up for that. You can drop off and pick it up. You can also submit it via the Quick Prescript app, and to a lesser extent, home delivery in special cases. So there are different ways to contact the NHF. You can chat with us online. You can call us, 906-1100. You can send us an email, info@nhf.org.jm. I know doctors don't have any time to visit us, but you can also visit our social media pages, where you can send a direct message to us, and we always have information there. And for this month, we are focusing on lupus. There's a blog out with Lupus Warriors. You can go and listen to that on our social media pages. So thank you very much. I don't know if we have time for questions. No. All right, thanks again, and I look forward to the rest of the presentation. I'll hang around to hear my cousin, Dr. Astrid Batchelor, for her presentation. Thanks again, all the best.
Thank you. Thank you very much, Mrs. Charmaine Robotham, for your continued support of the Lupus Foundation. Dr. Lou Jones, it's a nice purple jacket. Maybe we could manufacture a few and sell it with the Lupus logo, right? I put you in charge of that. All right. Well, we have to move right along. We're a little bit behind time, so at this time, I'm going to invite Dr. Lorianne Fisher to take over. Dr. Fisher?
Well, good morning, everyone, and thank you so much for your participation in our annual symposium. I am chairing the segment now on women's health in lupus, and the schedule has changed a bit, so Dr. Batchelor will be presenting next. And Dr. Batchelor is a proud alum of the Immaculate Conception High School and University of Pennsylvania. She completed her residency in obstetrics and gynecology at the University of the West Indies, Mona. During which time she served as a legislative chair. She is actually the chair of the ACOG Junior Fellows West Indies chapter, and she's now a fellow of the American College of the Obstetrics and Gynecologists, where she serves on the Maternal Mortality Council. She's also an associate member of the Royal College. She's currently a specialist registrar at Victoria Jubilee Hospital and is passionate about healthcare, education, promotion, and advocacy. And she's actually the recipient of the Marcus Garvey Public Sector Graduate Scholarship, and she'll be pursuing a master's in public health at the Johns Hopkins Bloomberg University next year. I'm gonna invite her now to talk on gynecological issues and preventative health in the woman with lupus. Thank you. Round of applause, please.
Good morning, everyone. And thank you, Dr. Fisher, for that introduction. And I would also like to commend the Lupus Foundation of Jamaica for having this conference and for inviting me to speak on gynecologic issues and preventative health in the woman with lupus. All right, so my objectives this morning is to raise awareness of common gynecologic issues seen in persons with lupus, familiarize physicians with the contraceptive options available for women with SLE, emphasize the importance of cervical and HPV screening to prevent high-grade squamous intraepithelial lesions and malignancy, how to approach pelvic floor dysfunction and sexual disorders in women with lupus, and of course speak about the management of menopause symptoms and osteoporosis in this population. SLE presents in women during puberty and early adulthood. As we know, about 90% of persons with lupus are women. And so these symptoms can span their entire reproductive lifespan. And gynecologists are uniquely placed in the healthcare continuum to treat women throughout their life cycle. Clinicians must therefore familiarize themselves about SLE effects on reproductive issues, the choice of birth control, pregnancy screenings, HPV-related cancers, menopause, and hormone therapy use. Providing care to women with SLE is multifaceted. Therefore, gynecologists will need to liaise with rheumatologists and other specialists and guide gender-related reproductive care. So just reminding you here, as I was saying earlier, that SLE is usually diagnosed between age 15 and 44, and so that spans the reproductive timeline in women. So just familiarizing ourselves with the female life cycle. We start here at puberty, and of course the most monumental event in puberty is the menarche, and then menstruation to follow. And in the reproductive years, issues that occur at that point in time will be sexuality and sex, infections to the genital area, family planning, which will include contraception, fertility, and pregnancy. And then as we move into the end of the female life cycle, we have menopause with issues such as osteoporosis, general aging issues, and of course the issue of hormone replacement therapy. So just getting the elephant in the room and talking about it first. SLE and the estrogen dilemma. So 90% of persons with SLE are female. And so given the adverse effects of female sex hormones described in numerous studies that have associated estrogen exposure and the development of SLE and the exacerbation of SLE, it's easy to accept that estrogens and SLE may not mix well. However, there has been no causal effect that has been proven between estrogen or any other hormone for that matter and lupus. More recent studies are showing that the disease, if the disease is inactive, stable, or mild, then exogenous estrogens, such as your contraceptives and HRTs, may actually be well tolerated in this population without any change in lupus activity. So researchers are now focusing on the differences between men and women beyond hormones that may account for why women are more prone to autoimmune diseases. So we start off, as we were talking about, with puberty. So SLE and menstruation. It's important to know that lupus can in fact affect the hypothalamic pituitary adrenal axis. This is the axis that controls our reproductive hormones in females and in males. And so girls with juvenile lupus may start puberty and menarche later than other girls, especially if their lupus is severe. And in addition to that, adolescents with SLE may also experience irregular menses when the disease is not well controlled. So this is important for the pediatricians to know that your young girls who are coming in with a history of prolonged amenorrhea or may come in with oligomenarche in their adolescent years, that lupus is actually a factor. And you can also, of course, make sure that you're ruling out other things as well, especially patients who are at risk of PCOS and other issues that may cause amenorrhea. But lupus in and of itself is also a cause for this. Many women may have an exacerbation of their lupus symptoms around the time of their menses as well. So you may notice persons complaining of increased joint pains, rashes, and fatigue around the time of their menses. This is well documented. And lastly, menorrhagia is a common complaint in persons with SLE, usually due to the blood dyscrasias associated with SLE, such as your lupus thrombocytopenia. Also, it might be from the anticoagulant use that some of them, or medications that they have to be on, so ensure iron supplementation. Some patients in menorrhagia may actually be severe, and they will have to use hormonal arrest of bleeding. So I'll use that as a nice segue now to talk about some of the contraceptive agents and hormonal agents that we use in patients with SLE. So Dr. Klaus earlier this morning had given a nice segment actually on contraceptives use in SLE. I'm wondering now if I need to go over in such detail in the interest of time, but I'll still say a few things. So family planning is an important clinical consideration in women with lupus. Why? Because there's a risk of maternal morbidity, mortality, and poor fetal outcomes when there is high disease activity in this population. And of course, there are some medications that are used to manage SLE and antiphospholipid syndrome that are contraindicated in pregnancy due to their teratogenic effects. So it's very important that we counsel our patients. Can change the slide. It's very important that we counsel our patients well about the need for contraception and the contraception methods available to them. Of course, there are barriers to contraception, and unfortunately, a lot of the times, the barriers are us as clinicians. Inconsistent use of contraception in patients with SLE may partly reflect limited screening, counseling, and gynecologic referral by rheumatology clinicians. Clinicians may advise patients against estrogen-containing contraceptives, sometimes because of the risk of disease flare or thrombosis associated with it. And this is in spite good data now that we have that these agents are actually safe in SLE patients who have inactive or mild disease. And then, so we're telling them, or we're shying away from prescribing estrogen-related contraception, but then we're also unfamiliar with the alternatives as well, such as the long-acting reversible contraceptive methods that do not contain estrogen. So when we're going to counsel our patients, these are some of the main things that we need to think about or bring up in our counseling sessions with patients. We need to counsel them about the risk of that contraceptive method versus the risk of an unintended pregnancy. The risk of lupus flares, the risk of thrombosis in pregnancy is way higher than the risk of thrombosis and lupus flares on medication. So you should not be shying away from prescribing medication for patients because of the risk of these medications when the risk in pregnancy is far greater in these patients. Of course, you have to think about the patient values and their preferences. If a method is unacceptable to a patient, she will not take it. So might as well you move on to another method. Of course, the ideal timing for pregnancy. As Dr. Klaus had mentioned, ask the patient when is it that she would want to become pregnant. Are you thinking about a pregnancy in 3 months, 6 months, 12 months from now, 2 years from now? That would also help you to know which method is appropriate for this patient if you're looking for a long-acting method or a short-acting method. Of course, efficacy is important. These patients have high risk of problems in their pregnancy, so you want to be using the most efficacious methods available. The side effects of the contraceptive method is important. For instance, Depo-Provera comes with the side effect of decreasing bone mineral density being used over 2 years. So this would not be a medication that you'd want to use in patients who are on corticosteroid therapies, which already put them at risk of osteoporosis. Underlying disease severity, of course, we need to know that. Are they actively in flare right now? So medications will not be useful. Does this patient have antiphospholipid antibodies? Do they have a history of thrombosis in the past? And of course, comorbidities. Patients with lupus have other comorbidities too. They may have hypertension, they may have diabetes, they may have seizure disorder. These are disorders that may already put them at a risk of using particular methods. So you know that already this method would not be ideal, even without their history of SLE. And then lastly, medication interactions. Some medications may actually decrease the efficacy of certain hormonal medications. Okay. So just giving you a chart here, just so you can see it for a second time today, about the effectiveness of contraceptive methods. So as you can see here, the injectables and the pills, those are giving you about 90% effectiveness against pregnancy. So about 9 in every 100 women taking the oral contraceptive pills may become pregnant with typical use. It's actually higher with perfect use, which a lot of women in our population don't get perfect use. We miss the pill every once in a while. And of course, that top line there would be your long-acting reversible contraception, such as your subdermal implants, the intrauterine devices, and of course, sterilization being a permanent method. These methods are going to offer you 99-point-odd% effectiveness. And these are really the methods that we should be talking about in persons with SLE once they're acceptable to the patient. All right, next slide, please. So let's talk quickly about intrauterine contraceptive device. They're safe, they're effective for most women with SLE and even persons that have antiphospholipid antibodies. They can be placed in adolescents, and they can be placed in nulliparous women. I know a lot of persons say that they didn't know that they can be placed in nulliparous women, and they definitely can be. You have 2 types. You have the copper-containing IUCDs as well as the hormonal IUCDs. The copper IUCD is great. There's no hormone in it, so there are less hormonal side effects associated with this method. But be aware that it can cause heavier menses and painful periods in some women. And then you have your levonorgestrel containing intrauterine system. This one can be used for 3 to 7 years, depending on the type that is placed. This one is known to reduce painful periods, and it also decreases menstrual bleeding. And so for you patients who are on anticoagulants or may have lupus-related thrombocytopenia, this method is actually ideal in a lot of those patients. And then we'll move into the subdermal implants. This is a great alternative for an IUCD, especially in patients who IUCDs are not acceptable, and in patients that estrogen cannot be used. The implant is available right here in Jamaica. We have the Levoplant, which is a 3-year system that releases levonorgestrel. Of note, is important that there are other preparations of subdermal implants on the market, like your Nexplanon and Implanon, mainly found overseas. These methods use a 3rd-generation progestin. 3rd-generation progestins have a higher thromboembolic risk associated with them, and there's a lack of data with how they perform with patients who have positive antiphospholipid antibodies. So the one that we have here in Jamaica is levonorgestrel, which is a safer version. So ours is quite safe. All right, and next we'll talk about the other progestin methods that are non-long-acting, such as your Depo-Provera injections and your progestin-only pills. As I'd mentioned before, Depo-Provera is a great method of contraception. If that is a method that the patient prefers, it's not that you should not put them on it. Just know that long-term use of this medication can decrease bone mineral density. So if you have a patient who is actually looking more for short-acting medications, like a 2-year or 1-year worth of contraception, is actually an appropriate method for the patient. And then you have the pills. The pills are found to be generally safe, and they can be used in patients with lupus anticoagulant antibodies. So we're talking about our estrogen-containing contraceptives. And just to put it out, they are completely safe to use in persons with SLE once the disease is stable and they have documented negative antiphospholipid antibodies. I know it may be hard in our population to get that testing done, but these are the patients who are allowed to use estrogen-containing contraceptives. If you are known to have a history of thrombosis or have antiphospholipid antibodies, that is a absolute contraindication to the use of estrogen-containing contraception. And of course, there are other methods such as the estrogen patch and the ring. Fewer studies are available on these methods, but typically the patch is not well prescribed because the exposure to estrogen in the pack may be unpredictable and excessive sometimes, and so we don't tend to use the patch. The ring has been used in persons, but as I was saying, there are fewer studies available on the ring. And then don't forget the barrier methods. They are not first line, and they're usually way less effective than these other methods, but sometimes barrier methods have to be used. For instance, in persons who are having an acute illness right now, or there's an acute thrombosis event that is occurring, then you may need to use a barrier method because other methods might be contraindicated. Also, it can be used in combination with other oral contraceptive medications as well, especially if they're on a contraceptive that may have some interference with other medications that might decrease the efficacy of that method. And of course, condoms are effective for reducing the risk of transmission of sexually transmitted infections. So if you have patients that are not in stable relationships, they're not STI checked right now, then condoms are always going to be a good option or a good addition to your contraceptive milieu of medications that you're using. So just my take-home message, LARCs are preferred. Remember, the levonorgestrel IUCD may reduce menstrual blood loss, which is particularly helpful for your patients on anticoagulation or with menorrhagia. Other progestin methods are good. Estrogen-containing hormonal contraceptives can be used, but make sure that the patient has inactive SLE and that they're not positive for antiphospholipid antibodies, and that we can still use barrier methods to reduce the risk of STIs. And as we're talking about STIs and infections, just to briefly mention, vaginal infections in persons with SLE is one of the most bothersome complications that they may come into my office with when they come in with recurrent vaginal infections, and namely yeast infections. So patients diagnosed with SLE carry an increased risk for vaginal and pelvic infections due to the immunosuppressive state from being on long-term steroids or other immunosuppressive agents. The incidence and prevalence of endocervical chlamydia and gonorrheal infections in women with SLE is pretty low and similar to that of the normal population. However, there is increased risk of dissemination, and so these STDs or these infections should be screened for and promptly treated. So in office, usually a safe thing to do is when the patients come for their annual pap smears, also add an STI panel to their investigations. Studies have found that a maximum corticosteroid dose of about 24 milligrams within the last 12 months was associated with the development of fungal infections, and that their absolute lymphocyte counts also was associated with the occurrence of candidiasis in SLE patients. Just reminding some persons about the agents that we can use. We can go to the next slide, because we see this quite often in our offices as gynecologists, patients coming in very frequently for candidal infections who have collagen vascular diseases. So general agents that can be used, your azoles are very good. And of course, if a patient is coming in 3 or 4 times a year or more than that in a year, then they have recurrent candida vulvovaginitis. And you really should think about the option of suppressive therapy in these patients. So suppressive therapy is generally for 6 months. And here are the options. You can do weekly or monthly fluconazole, 150 milligrams oral, daily ketoconazole, 200 milligrams, or weekly clotrimazole, 500 milligrams, and that's an intravaginal preparation. Remember that these medications can affect the liver, so it's important that you do a liver function test before starting your 6-month therapy and about halfway in, and then at the end of it, just make sure that the liver function is still optimal in these patients. Now, sometimes they get the resistant types of candida infections, and you should actually swab them to see what type of candida infection it is, because not all patients are candida albicans. You can actually be growing candida gibraltar as well, which usually are a little bit more resistant and harder to treat. So if these patients are failing your first-line medications, you can actually consider therapy with boric acid, 600 milligrams intravaginal for 14 to 21 days. And this has been a regime that has also been used in the American Congress of Obstetricians and Gynecologists. So let's talk about human papillomavirus. Let's stop here for a little bit and have a discussion about this. Women with SLE are especially predisposed to HPV infection. In fact, one of the newly identified causes of cancer in patients with SLE are going to be your HPV-driven malignancies, such as your cervical, anal, and oral cancers. Because of the increase in HPV morbidity in patients with SLE, routine HPV vaccination, Pap testing, and high-risk HPV DNA testing, together that's called a co-test, should be encouraged in this population. Because HPV is high risk. In a meta-analysis done in 2014 called Increased Prevalence of Squamous Intraepithelial Lesions in SLE and its association with HPV, we found some really remarkable information coming out of this study, that the prevalence of vulvar condylomas was higher in patients with STDs. The prevalence of low-grade lesions to the cervix was higher with SLE. The risk of high-grade lesions was significantly increased in patients with SLE compared to healthy controls. The prevalence of abnormal pap smears was significantly increased by about 3 times in the population. The prevalence of squamous intraepithelial lesions was increased 6-fold in patients with SLE. The overall prevalence of HPV infection in SLE patients and controls was 11.8% versus 7.8%. Infection with multiple high-risk HPV infections was also common in patients with SLE. And so independent risk factors were found to be that SLE was an independent risk factor for having the development of squamous intraepithelial lesions and HPV malignancy, also persistent high-risk HPV infections, and the use of cyclophosphamide. So this is a bit of a dilemma between the rheumatologists and the gynecologists, because patient is on cyclophosphamide, which might be driving this HPV process, but the patient needs their cyclophosphamide, especially if they have lupus nephritis. So how we can get around this? It's already here, the human papillomavirus vaccine. We know that they're at increased risk of getting these infections, so vaccination is going to be a powerful tool to prevent infections, even in immunocompromised patients. Most non-live vaccines are immunogenic and safe to use in patients with SLE. There is a quadrivalent and nanovalent HPV vaccine, which is well tolerated and reasonably effective in this population, and we have the HPV Gardasil 9 vaccine available here. So my recommendation for HPV prevention is the vaccine and screen. So make sure your patients are vaccinated. Ideally, they should have been vaccinated from age 11 or 12, but if we miss this timeline, vaccinate them once they present to you in your office. And of course, co-test patients. That's the combination of a Pap test and the HPV DNA testing. Low-risk patients are the ones who are negative for HPV DNA and have normal Pap smears. Those patients, you can probably rescreen them every 3 years with a co-test. And for your patients who are higher risk that came back positive for HPV on their DNA testing, these patients should have more frequent intervals and more frequent screens. I think that's a reasonable approach. Quickly, just talking about pelvic floor dysfunction. Now, this is an area that there's a paucity of publications in the literature on this. But we as gynecologists see this quite a bit, that patients with SLE, as well as other collagen vascular diseases, present quite frequently to the office with urinary incontinence, nocturia, incontinence, pelvic organ prolapse, and genital pelvic pain and penetration disorders, more so than healthy controls in this study. They were 3 times more likely to come in with disorder, these pelvic floor dysfunctional disorders. We're not sure why, but we think it might be a mixed picture sometimes, that there is a little bit of Sjögren's syndrome and fibromyalgia in patients with SLE, the SLE disease activity on the muscles itself, and also long-term corticosteroid use associated with muscle wasting and weakness may have an effect on the pelvic floor. So if these patients come to you, of course, approach to it would be take a good history, the timeline and severity of the symptoms, use of corticosteroids, how is it affecting their quality of life, examine the patient, rule out causes of pain and genital pain, rule out your infections, your STIs, check for steroid-induced diabetes because this can cause neuropathy and vestibulitis in patients. Request your pelvic ultrasound to rule out masses and find other causes of pain, and refer. Gynecologists and pelvic floor physiotherapists are best to manage these disorders. So, if you have pelvic floor dysfunction, there can also be sexual dysfunction as well. So let's talk about SEX and SLE. Problems with joint pains, fatigue, headache, weight gain, vaginal sores, and dryness and painful sex can make it hard for anybody to have sex, right? Or to enjoy sex. And one of the main things in life is to enjoy sex. So there are many important factors that come into play when we're talking about sexual function. The disease itself can prevent them from enjoying sex. In general, the greater the severity of the disease, the more sexual difficulties they may have. There's the side effects of the medications. There's the psychological factors. Persons with SLE may suffer from issues with weight gain because of their steroids. They may have lost their hair. They may have scarring rashes that affect their body image. So these are things that all needs to be addressed in these patients. And there are barriers to addressing them. We are the barriers sometimes as clinicians. Professionals are very silent about sexuality and intimacy in our patients because we always say, oh, the time is limited. We have to prioritize talking about the disease assessment and the treatment. Yes, the time is limited, but it's important that we discuss these things with our patients. We have to talk about sex and sexuality. We as clinicians have to be comfortable doing this because it's a huge part of life and their quality of life. So things we can do to optimize disease control in these patients: we need to pursue medications that will help to control their symptoms, that will reduce their pain and their fatigue. We can adjust their medications within reason. We can consider physical therapy that help them with joint motions and lessen their pains. They may need sex therapy and psychotherapy. I'm glad to see that Dr. Carmen Carpenter will be here. I hope she'll talk about that. And of course, simple things: treat their yeast infections and recommend vaginal lubricants in this population. And then lastly, we're winding down now. We're going into the last phase of life. This is the menopause and SLE. So all women experience menopause differently, including women with SLE. Menopause may help ease some lupus symptoms sometimes, and in others it may not. Women with SLE go into menopause about the same time as the general population. However, if you're on medications like cyclophosphamide and other glucocorticoids, it can cause premature ovarian aging. Women with SLE are at an increased risk of cardiovascular disease and osteoporosis due to the inflammatory impacts of SLE and the immunosuppressive therapies, but also now because of the menopause. We're winding down. So common menopausal signs and symptoms: you have the amenorrhea, you have the vasomotor symptoms like your hot flashes, the decreased bone density and osteoporosis, diminishing cardiovascular health, and vulvovaginal atrophy. So, menopausal hormonal therapy. Estrogen, as we discussed before, has the potential to cause triggers or flares, and especially in women in SLE. And so where possible, it is best to treat menopausal symptoms without the use of hormone replacement therapy. However, some women in general and some women with lupus can benefit from menopausal hormonal therapy because it improves vasomotor symptoms, it decreases osteoporosis, it maintains cardiac health and cardiac protection. So as a consequence, management of menopause symptoms needs to be evaluated carefully and treated in an individualized manner. So you should know the health status of the patient, the lupus history, and their cardiovascular and thrombotic risk before we decide to or decide against prescribing hormonal replacement therapy. So these are just some of the options that we can use. These are the non-hormonal replacement therapy options to treat vasomotor symptoms. And a lot of the time, a patient doesn't walk into your office saying, I'm experiencing osteoporosis. They're going to walk into your office saying, I'm experiencing hot flashes, right? So you have to know how to treat that with medication that are not hormonal replacement therapy. So name a few: your SSRIs, your pregabalins, clonidines. Of course, you have your supplements like black cohosh and evening primrose oil, relaxation techniques, and of course, cooling strategies. And now moving on quickly to osteoporosis, women with lupus are nearly 5 times more likely to experience a fracture from osteoporosis. This is because of glucocorticoid medications, pain and fatigue that may be caused by the disease that result in inactivity, further increasing osteoporosis. And studies have shown that lupus in and of itself is a factor in causing osteoporosis, and of course kidney disease that may be associated with their lupus nephritis. And so we need to prevent osteoporosis. So we need to stress these main things with our patients: nutrition, adequate vitamin D and calcium supplementation, weight-bearing exercises to improve bone health, reduce caffeine, alcohol, and smoking, of course. And rheumatologists can help us by doing this as well, by decreasing steroid exposure in the patients, by getting them down to the lowest dose of steroids when medically feasible. And of course, screen, screen, screen. Bone mineral density testing is going to be important in this population. So the DEXA scan is one of the most easily accessible bone mineral density testing available on the market. The general population usually will start screening between age 60 and 65. However, persons with SLE and persons who are at risk of osteoporosis will need to start screening earlier. So I can't tell you the exact age that you should start screening, but you can look at your patient's risk factors and decide when is a good time to start screening. For instance, for a patient who has been on corticosteroids for 10 years or so, that might be a good time to start screening. And then, of course, be guided by the Z-scores. If the patient is normal, you might wait a little bit before doing your next screen, but if they're at risk, you will treat and screen more frequently. And these are some of the osteoporosis treatments available. We as clinicians know most of them. First line would be to start with your bisphosphonates, and then there are also other measures. While you're doing this, also remember to do the preventative things as well, the nutrition, the exercise, and so forth. And then lastly, I can't end, this is my very last thing, I cannot end, we're in Breast Cancer Awareness Month. We need to know about breast cancer screening in this population as well. The incidence and prevalence of breast cancer in women with SLE is not increased compared to the general population, so therefore screening schedule remains the same, start at age 40 and screen annually. But it's important to know, last slide for me, that breast cancer does have a poorer outcome in patients with SLE than in the general population. There is a risk for mortality that was found to be higher among women with breast cancer with SLE compared to women who did not have SLE. Women with early stage breast cancer and SLE were reported to have a lower 5-year survival rate compared with women with breast cancer alone. Therefore, early detection is going to be key in this population. So please remind your patients that they have to start screening at age 40 and they have to screen regularly. So 3 things to remember will be your HPV DNA test, your pap smear, vaccinate your patients, send them for their DEXA scans when the time comes, and then of course, ensure that they're doing their breast screening. And this is my summary. Women with SLE require additional considerations for their reproductive care. It's important that the physician properly counsels patients about the effects of the disease, on their health and their medical choices. Contraception choices should be carefully selected in the patient population, weighing the benefits against the risks. Always consider the antiphospholipid syndrome status. HPV vaccination and cervical screening are vital in women with SLE and HPV-related malignancies, as they're significantly increased. Pelvic floor dysfunction and sexual dysfunction should be promptly referred and treated. Menopause coupled with SLE can increase the risk of osteoporosis and cardiovascular accidents in these patients, so prescribe treatments in an individualized manner. And lastly, estrogen can be used in patients with SLE once disease activity is mild or there is low risk of a thrombotic event. Thank you. Thank you for your time. I know I went a little bit over time, and I'm open to question and answers in that segment.
Okay, so thank you very much, Dr. Batchelor, for that excellent presentation. Just for the purposes of time, just for the purposes of time, I'm going to introduce our next speaker, Dr. Leo Walker, who unfortunately is not here at the moment, but we'll do a his video recording. So Dr. Walker is a consultant obstetrician and gynecologist, having pursued his medical degree at University Hospital in New York, University of the West Indies in 2011. He's a graduate of the DM program in 2018, and he's also completed his fellowship in maternal fetal medicine in 2021. He's going to talk to us today on infertility and pregnancy loss in lupus. So we're going to go to his video recording.
Hi, good morning everyone, and welcome again to the annual Hybrid Lupus Symposium, focus being on reproductive health and lupus. I'm Dr. Leo Walker, and this morning speaking about infertility and pregnancy loss. I'd like to take this opportunity to thank the organizers for inviting me to have this brief discussion. I hope you'll all enjoy it. Now, systemic lupus erythematosus has a clear predilection for women, 10 times more common in women than in men, with women of childbearing age being at particular risk. Now, the average age of onset is usually between 15 and 40 years. Within that, those prime years where women seek to fulfill their fertility potential. Now, as such, issues regarding family planning and pregnancy are an important part of the management of these patients. And not only does pregnancy itself cause physiologic and immunologic changes that can impact disease activity, but also women with SLE face the additional challenges of reduced fecundity or the ability to conceive abundantly and worsened pregnancy outcomes. Now, addressing fertility issues in these patients requires a multidisciplinary approach between reproductive medicine specialists, high-risk obstetricians, maternal fetal medicine specialists, as well as rheumatologists. Now, this collaboration maximizes the potential for a successful outcome, whilst also minimizing the maternal risk. So what are some of these fertility-related issues? Well, fertility is largely unaffected by the diagnosis of SLE itself. Women with SLE, however, do have on average smaller family sizes, and this is likely multifactorial. Now, these usually range from either increased disease activity, medication exposure, patient preference, physician advice, of course, and also a personal history of pregnancy loss and increased risk of stillbirth. Cyclophosphamide, for example, accounts for most of the non-age-related subfertility among women with SLE, and this risk appears to be related to both the cumulative dose, but also the age at which the drug is initially administered. For example, women who initiate cyclophosphamide therapy prior to the age of 30 years are less likely to experience this significant reduction in their fertility. With respect to dosage, patients who receive 6 or fewer monthly intravenous pulses, a cumulative dose less than 7 grams, and maintain a normal menstrual cycle prior to and during treatment tended to exhibit fewer alterations in their fertility. Other medications used in the management of SLE are less likely to have this similar impact on fertility. High-dose corticosteroids, however, can impact women's cycle. This is largely due to the interaction with the hypothalamic pituitary ovarian axis. Of course, this brings out the importance of ovarian reserve. As previously alluded to, patients with SLE may have menstrual disturbances and even amenorrhea as a result of very active disease and/or medications. Anti-Mullerian hormone serum levels, which is a pretty reliable indicator of ovarian reserve, simply because it is produced and secreted by the primordial follicles of the ovary. These are follicles which still have the potential to mature. These levels have been reportedly low among patients when compared to the age-matched controls. Additionally, lupus glomerulonephritis-induced renal insufficiency or failure can certainly lead to subfertility and infertility. Even though the exact mechanism through which this occurs is not well understood, it's thought that prolactin plays a significant role, likely because of the reduced clearance of prolactin secondary to the renal impairment. What about advanced maternal age? No, as with the general population, advanced maternal age is a significant contributor for subfertility among women with SLE. The onset of SLE is often during the early reproductive years, and patients are generally advised and do avoid pregnancy during active disease and at least 6 months post the last flare. So since female fertility declines with advanced age due to progressive loss of the ovarian reserve, many patients with SLE are usually older and they're attempting to conceive for the first time and may encounter these age-related difficulties. So fertility preservation, which now becomes key. Preservation of fertility focuses on limiting the use of cytotoxic medications when feasible. The ovaries throughout cytotoxic therapy. But it's important to note, of course, that prompt initiation of the most effective therapy for the severe disease would often and always takes precedence over a patient's fertility preservation. So oocyte cryopreservation are one of these techniques that we can use to preserve a woman's fertility, particularly those who are undergoing cytotoxic therapy. Oocyte cryopreservation is an effective option for preservation, but does have its limitations, particularly among women with active disease. Now, naturally, it requires ovarian stimulation, which may not be practical during active disease, given the usual need to institute prompt therapy. There's also the unwelcome risk of OHSS, ovarian hyperstimulation syndrome, which would surely complicate an already complex scenario. Ovarian hyperstimulation increases the risk of capillary permeability, which increases edema, which reduces renal perfusion and increases potential renal impairment in patients who already have a predilection for renal impairment. Now, this approach can be considered for stable patients with inactive disease or patients who are more concerned about the age-related fertility. One thing I forgot to mention with respect to OHSS is that the risk of thrombosis also increases with OHSS alone. So that combined with SLE obviously presents a further increased risk of thrombosis, so venous thromboembolic events and even arterial thromboembolic events. So in vitro fertilization, is there a role for in vitro fertilization? Simple answer is, of course. Controlled ovarian stimulation necessary for in vitro fertilization, however, may increase the risk of lupus failure by as much as 40%, as well as the risk of thrombosis. The risk appears to be directly related to the degree of 17-beta estradiol levels. So for these patients, what we typically employ are using lower dosages of these ovarian stimulation agents, or what we call step-up protocols. That simply means we use lower doses of menopur or human menopause or gonadotropin, gradually monitor the response to these medications and increase the dose in increments until we achieve the appropriate response. It should be mentioned that these flares that are usually noted during ovarian stimulation are mild and quite responsive to therapy. Options to minimize thrombotic risk, of course, for patients who are undergoing IVF procedures also involve the use of low-dose aspirin and or low molecular weight heparin, particularly those patients with who are positive for antiphospholipid antibodies, lupus anticoagulant in particular. Now, we've spoken about oocyte cryopreservation, the use of IVF. What about donor eggs? Now, this is an alternative option in pregnancy in women with either few or poor quality oocytes, women who are much older or women who have undergone cytotoxic therapy. In vitro fertilization using donor oocytes and a partner sperm may be performed in a period of quiescent disease and provides an additional option for pregnancy. So, of course, there's a multitude of options and will continue. Ovarian protection can also be employed. So, treatment with GnRH agonist prior to cyclophosphamide therapy can provide a substantial degree of ovarian protection. There's a study which recruited 20 patients who received leuprolide at least 10 to 14 days prior to cyclophosphamide therapy, and there was an estimated 68% increase in preserved ovarian function when compared to control. So this is huge. And this is actually a mechanism which is employed commonly in patients with gestational cancers who are due to undergo chemotherapy. They would receive GnRH therapy, 1 to 2 weeks prior to cytotoxic drug therapy. And this confers a great degree of ovarian protection. So these women can still maintain fertility even post use of these potentially gonadotoxic chemotherapeutic agents. That 14-day window, however, between GnRH agonist therapy and initiation of cyclophosphamide therapy is crucial. GnRH agonists will naturally have this initial stimulatory effect on the ovaries, which results in rapid follicular recruitment. If the cyclophosphamide is administered immediately following GnRH agonist therapy, it can actually have the opposite effect. So it can exacerbate ovarian damage. So that 2-week window that we use is quite important, but it's also the potential pitfall in that, these patients do require a whole 2 weeks before we can initiate that cyclophosphamide therapy. So for patients with active disease, this would not necessarily be a feasible option. What about the use of gestational carriers and surrogates? Not something which is commonly spoken about in our country here locally, because we simply just don't have surrogate laws or gestational carrier laws. But again, these are options. A gestational carrier is a woman who, of course, in quotation, simply carries and delivers child for another couple or individual, aka the intended parents, and lacks any genetic connection to the offspring. This is usually useful under the rare scenario where a woman may be suitable for in vitro fertilization, but not the physiological rigors of pregnancy. So, for example, a patient with systemic lupus erythematosus who has lupus nephritis and significant renal impairment. Pregnancy is likely to cause further progression in her renal impairment. So this woman may be suitable for in vitro fertilization, follicular recruitment, oocyte retrieval, but may not be able to handle those physiological stressors of pregnancy. So these are the ideal patients in which gestational carriers can be employed, can be used. They simply perform oocyte retrieval, fertilize those oocytes, and implant them in the suitable carrier. A surrogate, on the other hand, refers to someone who shares a genetic link to the child and is likely to be applicable. This option is likely to be applicable among those women whose ovarian reserve is significantly diminished. So you would have a woman who possibly received cyclophosphamide therapy in the past, and a significant reduction in her ovarian reserve, and therefore cannot conceive naturally, nor can she undergo, oocyte or ovarian stimulation. Couple would have identified a surrogate. That surrogate would now undergo oocyte stimulation, egg retrieval. Her egg would be fertilized by the intended father's sperm, and then that fertilized ovum is reimplanted into the uterus. Now a little bit about pregnancy loss. The rates of pregnancy loss are, of course, higher among patients with systemic lupus erythematosus and range from around 15 to 30%. Higher disease activity, particularly in the early parts of pregnancy, first, second trimester, contributes to a 3-fold higher rate of pregnancy loss as compared to pregnancies in which the disease is well controlled. Additional factors for pregnancy loss and stillbirth include women who have high disease activity even prior to pregnancy, the presence of antiphospholipid antibodies, particularly lupus anticoagulant, and those patients who are triple positive, lupus nephritis, and of course, hypertension. These are the factors that stand out in terms of the ones which are notable for increasing this potential risk of pregnancy loss and stillbirth. So this kind of moves us nicely into what we refer to as obstetric antiphospholipid antibody syndrome. Now, this specifically refers to those patients who exhibit what is referred to as the Sydney or Sapporo criteria. So those individuals who only have these obstetric or adverse pregnancy outcomes were also positive antiphospholipid antibodies. And while close to 1/3 of patients with SLE are positive for antiphospholipid antibodies, far fewer meet the criteria to be diagnosed with obstetrical antiphospholipid antibody syndrome. As mentioned, this specifically refers to patients with a history of pregnancy morbidity, positive antiphospholipid antibodies, and no prior history of arterial or venous thrombosis. So the Sydney or Sapporo criteria is what we use for defining the pregnancy morbidity associated with obstetrical antiphospholipid antibody syndrome. So the Sydney criteria is these three things: patients who have 3 or more consecutive unexplained losses at less than 10 weeks, or one or more unexplained loss at greater than 10 weeks in a structurally normal fetus, either assessed on anatomy survey or post-delivery examination, or patients who have had to deliver at 34 weeks or less, secondary to uteroplacental insufficiency. So that would include hypertensive styles of pregnancy, so those patients who develop preeclampsia, growth restriction, oligohydramnios, any of those factors associated with uteroplacental insufficiency result in a delivery less than 34 weeks. These patients would have met the clinical criteria for the diagnosis of obstetric antiphospholipid antibody syndrome. So, which women are the highest risk, however, for adverse outcomes? Alluded to previously, but lupus anticoagulant is the most powerful predictor for adverse pregnancy outcome in those patients who have positive antiphospholipid antibodies. In a prospective cohort study of singleton pregnancies, 39% of patients with lupus anticoagulant had adverse pregnancy outcomes. And among patients who did not have lupus anticoagulant, the frequency of adverse outcomes was at a maximum 8% for those with anticardiolipin antibodies, and 30% for those patients with anti-beta-2 glycoprotein antibodies. So as you can see, lupus anticoagulant definitely carries the highest risk for adverse pregnancy outcomes when compared to the other antibodies. Triple positivity also is a poor prognosticator. In a multi-center study of women with antiphospholipid antibody syndrome, despite being treated with low-dose aspirin and low molecular weight heparin, from the first trimester, only around 30% of these patients were triple positive had a live birth. Conversely, patients positive for a single antibody had live birth rates ranging from 48 to 80%. So these are things that we could use to easily prognosticate patients, which would help us to counsel patients, manage expectations, particularly in early pregnancy. Patients with thrombosis associated antiphospholipid antibody syndrome also have higher rates of pregnancy complications and fetal loss than those with only obstetric associated antiphospholipid antibody syndrome. Now, the underlying physiological mechanism for a lot of these complications appears to be, again, multifactorial, but the main factor is or relates to inadequate cytotrophoblastic infiltration into the deciduum basalis. Now, I always, think about that placental migration as a tree burying its roots into the ground looking for sources of nutrients. Those roots are usually big, usually resulting in very low resistance, a low pressure system. This is the same thing that happens in formation of the placenta. Implants itself into the uterus, looks for those large maternal vessels, remodels those vessels, and creates a low pressure, low resistance system. When there's inadequate cytotrophoblastic infiltration, this normal process doesn't occur. So what is formed is these small, very tortuous vessels. And there's also already this increased risk for platelet aggregation adhesion and thrombosis formation. So all of these things can compromise perfusion which already can increase the risk of pregnancy loss, miscarriage, stillbirth, but also those factors associated with uteroplacental insufficiency, so preeclampsia, growth restriction, oligohydramnios. So all of these things that we've spoken about, how do we minimize these risks and adverse pregnancy outcomes, particularly with respect to APLS? Now, use of antithrombotic therapy for pregnant patients with antiphospholipid antibody syndrome usually varies depending on whether they have APS based on prior thrombosis versus obstetric antiphospholipid antibody syndrome only. So let's talk about the patients with APLS with prior thrombosis. Now, non-pregnant patients with APLS based on lab criteria for antiphospholipid antibodies plus a history of arterial and venous thrombosis are naturally at a higher risk of recurrent thrombosis. Now, for these patients during pregnancy, use of therapeutic doses of low molecular weight heparin is recommended, and the risk of thrombosis in untreated patients is actually more than 10%. This is now compared to pregnant patients' average risk of thrombosis, which is just around 0.1%, so it's a significant increase in risk. Low-dose aspirin is also recommended as a risk reduction mechanism for preeclampsia. Of course, this is consistent with recommendations from the United States Preventive Services Task Force, but also the American College of Obstetricians and Gynecologists. Where possible, aspirin should ideally be commenced preconceptionally, otherwise it's commenced as soon as the pregnancy is confirmed. Again, this highlights, if it hasn't been highlighted already, the importance of preconceptional counseling. These are patients that ideally you want to see before they become pregnant, so they can be optimized as much as possible and remain free of any flares or disease activity at least 6 months prior to pregnancy. Now let's talk about patients with APLS with no prior history of thrombosis, so those patients with obstetrical antiphospholipid antibody syndrome. For treatment of these patients during pregnancy, prophylactic low molecular weight heparin is recommended upon confirmation of the pregnancy. And again, a low-dose aspirin, 81 milligrams once daily, is started. So in a trial of patients with previous pregnancy losses, the impact of aspirin on pregnancy loss and live birth was greater when started prior to conception and attenuated if the treatment was taken for less than 4 times per week. So this was just to highlight the importance of aspirin therapy. Now, how do we monitor both the mother and the fetus? And again, there are different ways in which this monitoring process can occur. Initially, we talked about lab investigations. I also mentioned a little bit in terms of sonography. With respect to the labs, as in all pregnancies that increase risk of complications, frequency and content of prenatal care in APLS is tailored to allow for timely intervention in the event of maternal and pregnancy complications such as preeclampsia. Now, in order to intervene in a timely manner, we have to be able to recognize when these changes are occurring. Of course, recognize them early. The only way that we can accomplish that is by doing some baseline investigation. So a baseline complete blood count, urea, creatinine, electrolytes, 24-hour urine collection or the urine protein to creatinine ratio, baseline liver function test. All of these things will serve as a comparison event of active antiphospholipid antibody syndrome or other complications later on in the pregnancy, such as flares, lupus nephritis, so on and so forth. It's also important to screen for some associated antibodies, the anti-Ro, anti-La antibodies, because these have significant implications on the fetus in terms of the risk of neonatal lupus or complete heart block. With respect to sonography, early dating scans are crucial as the majority of these patients will require scheduled deliveries, routine anatomy survey, which is standard for all pregnancies, but also increased fetal surveillance. So we tend to perform serial growth scans every 3 to 4 weeks and Doppler velocimetry starting in early third trimester at around 28 weeks, with weekly fetal testing, so either non-stress test, or biophysical profile. In some patients, particularly those who are poorly controlled disease, we may actually employ twice weekly fetal testing. In the absence of standard medical or obstetric indications for early delivery, of course, those include things that we've mentioned before: preeclampsia, growth restriction of the hydramnios, non-reassuring fetal testing. These patients can be delivered at 38 to 39 weeks following the discontinuation of antithrombotic therapy. So aspirin is usually discontinued by around 36 weeks, and these patients are usually admitted and transition from low molecular weight heparin now to unfractionated heparin. Again, we're able to control the infusion much better. And of course, unfractionated heparin has a reversal agent should these patients go into labor spontaneously during the admission. For postpartum care, anticoagulation can generally be resumed around 4 to 6 hours post-vaginal delivery, around 6 to 12 hours following a cesarean section, providing that these patients are not at an increased risk of bleeding. So patients with uterine atony, for example, patients with significant postpartum hemorrhage, we may want to delay resumption of the anticoagulation therapy in the postpartum phase. For women with prior pregnancy morbidity or APLS pregnancy morbidity, this low molecular weight and aspirin should be continued throughout the puerperium, so all the way up to 6 weeks postpartum. The exception is for those women in whom the pregnancy morbidity was a prior delivery at 34 weeks as a result of uteroplacental insufficiency. For those women, if they had undergone a vaginal delivery, they can simply be placed on aspirin up to 6 weeks. However, for those who undergone C-section in that particular clinical scenario, they would continue both the aspirin and low molecular weight heparin. Now, we do have patients who do all the right things. Start aspirin prior to pregnancy, they're started on low molecular weight heparin, but they still have poor pregnancy outcomes. What can we do for these particular cohort of patients? Now, patients with obstetric APLS treated with low-dose aspirin and low molecular weight heparin may require additional treatment measures, as conventional measures may fail to prevent obstetric morbidity in around 20% of cases. Now, for these patients, there is actually no second-line therapy with proven efficacy. So there's nothing that has been analyzed, gone through robust trials and have been proven to be effective among these patients. But there are some things that we can use. Hydroxychloroquine appears to actually depress antiphospholipid levels, and this effect might be beneficial in patients with APLS-related recurrent pregnancy loss. However, it takes approximately 3 months for hydroxychloroquine to have an effect, and thus it should be started well before attempts at conception. There's small trials which show some benefit, but there's no high-quality data available to indicate this benefit. There's also the role of IV immunoglobulins and prednisone. Meta-analysis of randomized trials found a reduction in recurrent pregnancy loss in patients receiving aspirin plus low molecular weight heparin plus IVIG, as well as patients receiving all of them: aspirin, low molecular weight heparin, IVIG, and prednisone. When used, the low-dose prednisone is preferable. High dose appears to be preferable to the high dose, as it appears to be as effective, as well as it reduces that potential risk of both maternal and fetal morbidities, so fetal growth restriction, onset of preeclampsia, GDM, pre-prom, and preterm birth. And I believe that is it. I hope I didn't go over my 20 minutes. But thank you guys for listening. And if you have any questions, please, now is the time to ask.
So as you can tell, we're operating on Jamaican time, so we're pretty behind. So I'm going to limit the Q&A to just one question per speaker, if possible. So if there were no questions from the video chat group, but if anyone has any questions at the moment, please feel free to ask of any of our speakers. I guess I have one question, which was to the first speaker. So the Gardasil is not often given as an internist and nephrologist. I don't give Gardasil. So oftentimes we, which provider would be the best person to give like vaccination advice, in your opinion? And how readily available is it for our public patients who may not be able to afford it privately?
Okay, thanks for that question. So Gardasil, we have
two preparations, Gardasil 4, Gardasil 9. Actually, right now, I think from our distributors, it's mainly Gardasil 9 that's being sold on the market. General practitioners, as well as gynecologist office usually have it. I know pediatrician offices who also carry it, because the ideal timeline to vaccinate patients is actually between age 11 and 12. So quite a few pediatricians I know offer Gardasil vaccination as well. So pediatricians, general practitioner offices, and of course gynecologic offices. It is sold directly from the distributor with a prescription. Sometimes we send the patients to purchase it and come back to the office and have the vaccination done. That's one option. The vaccine is actually quite expensive. It's about $18,000 per dose right now, and it's 3 doses over 6 months. There are a few insurance providers that may give a small subsidy, might take off about $2,000 or $1,000 from the cost of the medication per dose. So mainly it's going to be privatized at this point in time. So for our public patients, unfortunately, they will have to purchase the Gardasil 9. There was a point in time where the Cervarix vaccine, which is the competing brand, was actually being given in school-age girls here in Jamaica. I'm not sure how that program is going right now. I was told that it was halted, but there was a time where there was Cervarix that was being offered. But I would still, even though it is expensive, one caveat I do tell my patients, anything with cervical pathologies is very expensive to treat. Colposcopies, LETS procedures are very expensive. So prevention is better than cure. Prevention is cheaper than cure when it comes to the cervix as well.
All right. Thank you very much. And I'm going to take this time to thank our excellent speakers for giving really, really insightful talks today. And if there are any other questions, I'd probably just defer to the live chat if possible. I'm going to welcome back Cedric to continue his great job.
Thank you very much, Dr. Louis Fisher and the panelists, and wonderful presentations. I'd just like to give a couple of shout-outs to the lupus support group in Western Jamaica. I know they're online watching. I'd like to shout out to the Optimist Club of the Edna Manley School of the Visual and Performing Arts. And they'll be presented later, but I would like to give a shout out to Drs. Sandra McLeod, Dr. Stacey Davis, and Dr. Karen Carpenter. We're going to change up the program a little bit. We're going to take a break shortly for 6 minutes. Volunteers will assist you with some refreshments, no liquor. But we have a special presentation from the Edna Manley School, and her name, and she has been sitting right there, is Nevrona Campbell. And I would like to welcome Nevrona, and then we'll proceed to the 6-minute break afterwards. Thank you.
Good day, everyone. I hope that this song that I'm going to sing will just lift your spirits today. Don't mind the phone. I'm just, looking at the lyrics. All right, thank you very much. But I'm not broken, wounded, but time will heal. Lonely the road I trod, I dare, heavy the load, the cross I bear, shaken, but here I stand. my way through. Trials may come to make me strong. I must endure. I must hold on. Yeah. Oh. Yet still I rise, never to give up. Oh, never to give in against all odds. Yet still I rise high above the clouds. At times I feel low, yet still I below, yet still I. At times I feel low, yet still I. Yet still I rise, never to give up. Oh, never to give in against all odds. Yet still I rise high above the clouds. At times I feel low, yet still I. At times I feel low, yet still I. At times I feel low, yet still I
Wonderful, Nerona. Oh my. This could almost be the anthem for the Lupus Warriors. Still I rise. Absolutely amazing. Just before the break, I'm going to ask one of our director, Mr. Pete Smith, to come up to make a presentation, followed by Dr. Sandra McLeod. And then we'll proceed to the break. And this will be the only break. All right? So we'll just come back in quickly. Thank you.
Dr. Astrid Bachelor to join me at the lecture. Dr. Bachelor, thank you very much for such an insightful and very frank discussion you had, and I think that we're all even better off for it. Truly appreciate it. Thank you very much again on behalf of the Foundation.
for your time, your expertise, and your comprehensive coverage of the topic. Thank you so much.
I'm Dr. Desiree Tulloch-Reed, President of Lupus Foundation of Jamaica. This year, I invite you to give your support to Lupus Foundation of Jamaica. Your funds will help support our Learning and Help Center, helping persons get information, access treatment, and connect to a support network. Support our warriors through our helpline, monthly support group meetings, medical expense and social assistance, including food and critical supplies for needy lupus patients. You will also help us sustain educational programming, an interactive website, public awareness campaigns, and community outreach. Source medical equipment to improve diagnosis and treatment, and advocate with policymakers to improve access to care, and more. Lupus Foundation of Jamaica is a volunteer-run, donor-supported, registered charitable organization. Our funding is entirely through donations and fundraising activities. We need your help to continue the work for our lupus warriors and their caregivers who depend on us for information, support, and advocacy. Make your tax-deductible gift this season. Support the LFJ, support a warrior. Join the fight today. You can make a quick, an easy donation right now on our secure payment page. And help us raise funds by sharing with your family, friends, and coworkers to help us reach our goal. Consider becoming a sustaining donor by adding LFJ as a beneficiary and setting up monthly payments on your online banking platform. Give what you can afford. Every mickle make a muckle. I'm Dr. Desiree Tulloch Reed, President of Lupus Foundation of Jamaica. This year, I invite you to give your support to Lupus Foundation of Jamaica. Your funds will help support our Learning and Help Center, helping persons get information, access treatment, and connect to a support network. Support our warriors through our helpline, monthly support group meetings, medical expense and social assistance, including food and critical supplies for needy lupus patients. You will also help us sustain educational programming, an interactive website, public awareness campaigns, and community outreach. Source medical equipment to improve diagnosis and treatment, and advocate with policymakers to improve access to care, and more. Lupus Foundation of Jamaica is a volunteer-run, donor-supported, registered charitable organization. Our funding is entirely through donations and fundraising activities. We need your help to continue the work for our lupus warriors and their caregivers who depend on us for information, support, and advocacy. Make your tax-deductible gift this season. Support the LFJ, support a warrior. Join the fight today. You can make a quick and easy donation right now on our secure payment page and help us raise funds by sharing with your family, friends, and coworkers to help us reach our goal. Consider becoming a sustaining donor by adding LFJ as a beneficiary and setting up monthly payments on your online banking platform. Give what you can afford. Every mickle make a muckle.
Hello, the music is good, but we have to reconvene. We're just trying to get everybody from outside. So, Dr. Lori, can I ask them to come in for me, please? Let me see if I can. Hello, everyone. There's still, we're going to start. We're going to start in 2 minutes, all right? Okay, everyone, we're gonna start because we're running against the clock. As I said, that we should be dancing in between, right? Right, Dr. Stacy, you gonna lead us into the dancing? No, that's a big dance there, you know, Dr. Lou Jones. Eh? Right? I think that I'm going to invite Dr. Lou Jones to come and take us through to the next segment. She'll be our moderator. Hopefully the others outside will come in and join us. Right, Dr. Tollereed? You look very relaxed now. Eh? I said I'll give them 2 minutes, but the 2 minutes up already. So, okay, with your permission, then we'll move on. Dr. Lou Jones, floor is yours.
Good afternoon, good afternoon. Welcome to the afternoon session of the Lupus Foundation of Jamaica Reproductive Health series. I have the great pleasure of introducing our next speaker. Although it says Dr. Scott Brown, we're going to introduce Dr. Elon Thompson as our next speaker, who is a consultant urologist, having obtained his MBBS from the University of the West Indies, Mona campus, and then went on to complete his DM in urology in 2016. Of note, he wants us to know that he was the youngest urologist at that time in Jamaica. Through the Southern Alberta Institute of Urology in Canada, Dr. Thompson received training in minimally invasive procedures for kidney stones and cancers. He is currently employed to the Southeast Regional Health Authority and leads the recently started urology service at the Spanish Town Hospital, which I think is a fantastic new venture, and we hope that urological services will flourish under his mentorship. He also actively practices privately in multiple offices. He's also the immediate past president of the Jamaica Medical Doctors Association from 2016 to 2020, and have effectively provided representation for all doctors below the level of consultants in the public sector. He's currently the treasurer of the Jamaica Urological Society and a member of the Caribbean Urological Association. Please give us a warm welcome to Dr. Elon Thompson.
Good, I was about to say morning, afternoon to everybody. I want to thank the Lupus Foundation of Jamaica for inviting a urologist to come and speak about lupus. When I first got the invitation, I was wondering, I cast my mind back to my medical school days, and I remembered that lupus was predominantly a female disorder. And even though I treat females, my practice, of course, being a urologist, is predominantly males. And then I said, Elon, think back. I have a friend who was recently, a male, who was recently diagnosed with lupus. And I thought it was an opportunity now to shed some light on men's health and how it relates to lupus as well. So I have no disclosures. This is the outline of the presentation. I plan to be as brief as possible. We'll go through the introduction, some of the epidemiology, the clinical presentations, the related urological conditions, management considerations, and of course the summary. Now, I had to do some research about lupus, of course. It is more of a medical disorder, but I found definitely that there are considerations for urologists and surgeons. Now, it's a chronic heterogeneous autoimmune disorder, as we have been told more and more throughout the morning. It's the most common type of lupus. It still has an unknown etiology. It's really where the immune system attacks the body's own tissues with widespread inflammation and tissue damage in the affected organs, the kidneys, skin, joints, brain, heart, and other organ systems. Now, the treatment is mainly medical with the use of medications and, of course, lifestyle modifications. Currently, there exists no cure. I'm sure the Lupus Foundation is, working along with the international bodies to try and see how we can continue the fight against this disorder. As I said before, it mainly affects women, but men can be affected as well. Now, interestingly again, it's more common in persons of African descent. In the North American literature, you will identify that they use the term minority. I choose to use the word African descent, and there are other ethnic groups that are more affected. It's uncommon in men, so 1 out of 10 persons diagnosed with lupus is male. Women are 8 to 15 times more likely to be affected than men. We still are a little bit unclear why it's so highly prevalent in women, but of course there are theories, and it's thought to be multifactorial. It has been mentioned before that there is definitely a strong hormonal component in the pathogenesis. This has been borne out in animal studies. Prior to Dr. Batchelor's presentation, I had been informed and read about exogenous hormones really, being associated with the onset of lupus and related to flares. But she has pretty much given us some more information and insight into that theory. She also showed us that it really affects women of childbearing age, mostly. In men, though, the hormonal effects are really not that clinically significant. And there have been studies that showed that there is no evidence of hypogonadism or androgen deficiencies in men. It's more common in men with Klinefelter syndrome with the genotype XXY. There was a study that reported a more severe course in men with SLE and Klinefelter syndrome. And, query whether this may suggest that there's a sex hormonal link as well. Other studies have reported that there's no change in the profile of sex hormones in men with SLE when it's compared to the controls, and this may have some significant bearing on what really happens with the clinical manifestation when it comes to sexual dysfunction. The study actually looked at serum testosterone, estrogen, and prolactin levels that showed no change. Of note, in that study, it demonstrated that there were higher levels of gonadotropins that were noted. Now, with any disorder that has this long list of symptoms, it's going to be a challenge, I guess, to diagnose. Thankfully, it's not my task to diagnose lupus as a urologist, but just to note that the symptoms may range from mild to severe, and we have a long list here. Fatigue and skin rashes, I think, are by far the most common presenting features. joint pain, sun sensitivity, alopecia. They can have heart problems, kidney problems, as we've heard, seizures, psychosis, weight loss. These are all some of the symptoms. So the diagnosis is dependent on the index of suspicion. And now, if it's not common in men, there is probably going to be a tendency not to look for it very often in men. So, you know, when you're looking for a disorder, it's usually based on what we know about the disorder and who is at risk and who is it most common in. So we tend to look for it. So it's really dependent on an index of suspicion. So women are identified earlier than men because there's a higher index of suspicion in women. And it may also be a tendency of men to not have very good health-seeking behavior. And this is something that I believe that we have to try and, you know, address head-on in our country with regards to many conditions. Men may also demonstrate an atypical phenotype on presentation as well. Now, the diagnosis is based, of course, on history and examination, blood and urine tests. Some of this would have been dealt with already. ESR, anti-nuclear antibody, which has good sensitivity for lupus. There are other things that are important, especially in the urine analysis and urine microscopy, which demonstrates whether the disorder has any component, whether it's really surgical or medical, with regards to hematuria, whether it's microscopic or gross. And of course, you can do biopsies, whether of the skin or kidneys, to make the help with the diagnosis. Now, the drug therapy is also very expansive. NSAIDs, corticosteroids, antimalarial drugs, immunosuppression agents. I know cyclophosphamide was mentioned before. There are other agents that are used. BLYS-specific inhibitors like melumbamab, that was, I think, approved some years ago by the FDA for use. And we did talk about anticoagulants as well. Now, quickly moving into the related urological conditions. Now, gross or microscopic hematuria is a significant reason for patients to be referred to the urologist. Of note, you know, we need to determine whether it's painful or painless hematuria. And hematuria is where they have blood in the urine pretty much. So for the persons who are unclear, blood in the urine may be microscopic, meaning we can't see it with our eyes, but we see it underneath a microscope, or it may be gross, where we can see it with our eyes, so we see literal blood in the urine. Now, SLE has been shown to be associated with a higher risk of renal and bladder cancer. And these two cancers, the most common presentation is with blood in the urine as well. As I said before, when we're looking at hematuria, we can either determine whether it's medical arising from the glomerulus, whether you have red cell cast, or whether it's surgical in nature. Now, this has also been dealt with as well, lupus nephritis. It can actually be the initial presentation of lupus in up to 20% of patients. About 60% of lupus patients will develop clinical nephritis. Males tend to have disease earlier. This was demonstrated in a very limited evidence study, a retrospective study that demonstrated that males had an earlier onset of disease for nephritis. Microscopic hematuria is by far more common than gross hematuria in lupus nephritis. And as been discussed, a renal biopsy is really used to diagnose this condition. Now, interestingly enough, we had a recent grand rounds, and there again, lupus cystitis actually came up in the grand rounds because it was really the only diagnosis that was left to consider, and the patient that was presented had all these classic findings of lupus cystitis. It's a relatively rare condition, and only case reports have been reported in the literature. Men represent about 8% of the patients affected, so again, most of the persons affected by lupus cystitis are women. The exact mechanism is not fully understood, but it is thought to be tend to due to, result of fibrosis in the bladder from the chronic inflammation that exists in the condition. What happens is there's a progressive reduction in the bladder capacity, and patients will present with symptoms of frequency, urgency, nocturia, on occasions dysuria, dysuria as a result of the storage loss that they experience. So we have to be aware of these features, which can also be present with lupus nephritis as well. Now, cyclophosphamide-associated bladder cancer is a condition that can occur with continued use of cyclophosphamide. The usual presentation is with hematuria. Screening is important, and we really ought to look out for these cancers by investigating from the history and examination and really asking the patient these questions, because sometimes they won't volunteer that they're having blood in the urine. They may see it and it goes away, and they think that it's not anything really. But really, when you have patients on cyclophosphamide, you need to be keen on this. Most of the cancers associated with cyclophosphamide use are high grade and they're more aggressive. Some series report up to 50% being muscle invasive, which is a more advanced type of bladder cancer. Surveillance in these patients is necessary with follow-up cystoscopies when patients have been diagnosed with bladder cancer. Now, on to, I think, a bit of a point of controversy in terms of how we address sexual dysfunction in men. A lot of persons, when they see men, they may not ask pertinent questions about sexual health, as was discussed before. It seems to be still a taboo discussion among a lot of physicians. And for me, as really a men's health doctor, so to speak, we have to have these kind of intimate discussions about what's happening with erection, sexual function, fertility issues. All of these discussions have to come up. So really, we really ought to take a biopsychosocial model type approach to patients, with regards to this problem. So with regards to sexual dysfunction, there's an increased risk of male infertility with SLE. The treatment with cyclophosphamide can reduce your sperm count, and it may reduce testosterone levels in these patients. The psychosocial aspects of the disease are very important to consider because they may also be, in and of themselves, be related to erectile dysfunction. The patients tend to be on medications that can also lead to erectile dysfunction. So we have to look at the medications that these patients are on and evaluate them and see if this is really the cause of their erectile dysfunction. Now, interestingly enough, I came across these two quotes. We're doing a lot to attend to the sexual needs of women, and maybe we've ignored the men. Most lupus doctors tend to be women, and I see a lot of doctors who treat lupus in the house, and they are women. And it's harder for men to bring up their sexual stories to us. And this was a quote or a comment made at the American College of Rheumatology meeting in 2018 by a physician. So we really have to delve into the sexual health history to really unearth some of the issues that men have to deal with. I see a lot of men who come with erectile dysfunction. I see a lot of men who come with male infertility. May not necessarily be related to lupus, but if we have a lot of men in society having this issue, I'm sure the men who have lupus in the country, they are also suffering with this problem. Now, my baby, so to speak, prostate cancer. Now, there is little evidence, I would say, that suggests that there is a lower risk in patients who have SLE. I wouldn't take this to mean that men with lupus shouldn't be screened at the same age of somebody who does not have lupus. I would still recommend that because our population has a high risk for prostate cancer, that we should continue to screen persons once they have reached the age of 40. And screening for prostate cancer is done with a PSA blood test, prostate-specific antigen, and a digital rectal examination to examine the prostate to see if there are any abnormal nodules on the prostate. Of course, for the audience here, early detection can lead to cure. We've just come out of Prostate Cancer Awareness Month in September. Not getting as much attention, just like Lupus Awareness Month, so we are in the same boat. So we need to fight together, because I see a lot of pink all around the place for breast cancer, everywhere you go. Even at my office, that has an oncologist there, she has pink all around. I didn't get any blue last month. but so we just need to try and push the awareness, because there are persons who are suffering with different conditions that in and of themselves, they are suffering, so we need to be mindful of that. Just to remind the audience, advanced prostate cancer really may or may not have any symptoms, so do not wait for symptoms to get screened. There's this common concept in Jamaica that men, oh, I'm passing my urine okay, I don't have any difficulty, I don't pass blood, I don't this, I don't that, and yet you could still have prostate cancer right there. I've seen it many times. All right. So in terms of some management considerations, all patients with gross hematuria requires a cystoscopy. What a cystoscopy is really using a camera to look inside the bladder and to assess where the source of bleeding could be from. These patients also need cross-sectional imaging with contrast if their renal function permits. An ultrasound has a role, but it's limited, because an ultrasound may miss things like ureteric stones, they may miss smaller stones in the kidney, and they don't necessarily give you an outline of the collecting system very well. Referral is also important for these patients who have gross hematuria. All patients, whether it's once, half a time they had gross hematuria, a quarter time, they need to be referred because they need investigation. Urine cytology can be used to detect any cancer cells that may be in the urine, may be indicative of an upper tract lesion from a cancer or a bladder cancer. In patients who have obvious lesions in the bladder from imaging or cystoscopy, then it would be pertinent to do biopsy for these patients. With regards to biopsy of small renal masses, as I said, lupus patients are at higher risk of having renal cancers, and it really depends on the patient's clinical status that will determine whether we offer them biopsy, yes or not. The other thing that is important in terms of biopsying small renal masses is really where the mass is located. So if it's located near to where the blood vessels are, then we tend not to want to go so close to the blood vessels and do the biopsy. So we may have to look at other options that are available. Partial nephrectomy may be the best way to go to spare nephrons, and this is where we remove just the lesion in the kidney, and we try to spare the other part of the kidney that's unaffected. There are ablative therapies that are available in Jamaica. Radiofrequency ablation is available here, and that can be used for small kidney masses as well. Why are we being so aggressive with renal masses? The majority of them are cancerous. So once there is a renal mass, chances are it's a cancer. So we need to investigate it thoroughly. Radical nephrectomy, this is where we remove the entire kidney, and this may be necessary in larger masses, and especially masses that are close to the hilum. The laparoscopic option is available and is actually preferred when it is feasible. All right, now erectile dysfunction, big taboo topic among men. And as I said before, the biopsychosocial approach is preferred to treatment of this condition, because there is a significant psychosocial component to it. Usually we do lipid profiles on these patients, HbA1c to screen for diabetes, luteinizing hormone, testosterone, ECG, and we do advise lifestyle modification, because there have been multiple evidence to suggest that just exercising alone will be a natural way to increase testosterone levels. And in terms of medications, usually our first line of medication is really a trial of PDE5 inhibitors. A lot of persons may know about Viagra. The drug name is sildenafil. There are other agents in that group, tadalafil and vardenafil. Tadalafil currently is being used as well for patients who have benign prostatic hyperplasia, which is just a simple term meaning prostate enlargement and lower urinary tract symptoms. Now, the good thing about tadalafil is that we can use it for men who have enlarged prostate to treat the issues with flow and how they pass their urine, and also use it to treat the erectile dysfunction as well at the same time. So this is a wonderful drug that I like to use for a lot of men because it gives you the added benefit for the erectile dysfunction. No, it's administered at 5 milligrams once a day. The only problem with it, and I'm glad that NHF is here, is that it's what we would use instead to treat the lower urinary tract symptoms, tamsulosin, which doesn't give any benefit to erectile dysfunction, is actually on the NHF. So tamsulosin is on NHF, while tadalafil is not. I guess NHF is recognizing its use mostly as a erectile dysfunction drug and not more so as a prostate enlargement, lower urinary tract symptom drug, which is understandable, but that's why we continue to fight to try and get this drug more affordable and on the NHF for that purpose. Now, there are other options to treat erectile dysfunction. One of them is intracorporeal injections, which Trimix is the most commonly used one. It is available in Jamaica. There are vacuum devices that can be procured as well that can help with erectile dysfunction. And then last resort, for all persons who are not responding to any other treatments, is really a penile implant. And that's where we have a prosthesis that is surgically placed to give an erection at any point in time when it is needed. So it is the last resort. It's very expensive, but it is a very good option for persons who can afford it. So it costs about, I would say, for the prosthesis itself is close to $1 million, and then the surgery is probably another $1 million. So it's pretty expensive. Now, for persons who present with male infertility, prior to starting treatment, they may consider sperm banking. And this was discussed a little bit in the previous presentations. And sperm banking is available in Jamaica for persons who are desirous of future conception. And we advise that it should really be given before we start treatment for lupus. It's available through the fertility management unit that has a sperm bank there that they can go and donate. And I've actually sent patients to utilize that service before. Now, with regards to male infertility, it's usually found when the semen analysis has some abnormal parameters. And semen analysis is really important to make the diagnosis. Now, another issue is with how the semen analysis is done. It's done through masturbation most times, but there are other techniques that can be used to actually get the sample. Now, I know there are a lot of men who have issue with how the sample is supposed to be produced, and I can understand that. But I usually encourage them, and we usually, are able to work around how to get the sample. Because we do need to get treatment for these persons. So they usually see the bigger picture that we need to get treatment, we need to get the sample. This is the only way, really. Scrotal ultrasound is important to look at testicular volume, any other abnormalities such as varicoceles, blood testing to look for the luteinizing hormone, follicle-stimulating hormone, testosterone, total and free. Prolactin levels are also important in male infertility management. Now, with regards to lupus cystitis, it's really important to start treatment early because it will help to reduce the poor outcome of the disease. Various therapies really have been tried. Steroids and immunosuppressants have remained the mainstay of treatment. But really what we want to prevent is patients going on to have significant scarring in the bladder and as a result develop upper tract dilation, which we call hydronephrosis. So this is where there's obstruction of the kidneys and patients who can ultimately develop renal failure. So this is always the urologist's role here, is to try and relieve obstruction and prevent persons from going into kidney failure. Trying to give the nephrologist less work to do with regards to dialysis. All right, I think we're at the end. So just to summarize, SLE is not common in men. It can be a debilitating condition, however, for men. Early diagnosis and management can reduce the anxiety and morbidity associated with the disease. And sexual dysfunction requires more clinical attention to improve men's sexual health. I thank you for your attention.
Thank you very much, Dr. Thompson, for that very eye-opening talk on men's health, an often forgotten topic, because as you rightly said when you started, it's a room filled with mostly women. It's a woman predominant disease, and mostly many female doctors here. We're going to hold questions until after the second talk, and we're going to go straight into the second talk for this segment by Dr. Peter Gay Scott Brown. Unfortunately, she isn't here today, but she have sent her pre-recorded video. She is a consultant pediatrician based at the Bustamante Hospital for Children. She did her undergraduate and postgraduate training where she achieved her specialty. She went on to further subspecialize in pediatric rheumatology at the McGill University in Montreal, Canada. Currently, she co-manages general pediatrics at the hospital with bi-weekly clinics, as well as also covering pediatric rheumatology. She's a committed Christian and devout wife and mother. And so, without further ado, Dr. Peter Gay Scott will be presenting on reproductive health needs of the child and adolescent with lupus.
Reproductive health needs of adolescents with SLE. I have no financial relationships to disclose, and I am not an expert in reproductive health. These are the references that were used to prepare this presentation, and these are the areas that will be covered during this talk. Systemic lupus erythematosus is a chronic multisystem autoimmune disorder. Pediatric systemic lupus erythematosus is defined as onset of SLE in patients younger than 18 years. The average age of onset, however, is about 12 years, and rarely will cases occur in children who are 5 years old or younger. Pediatric SLE is estimated to account for approximately 15 to 20% of all SLE cases. And the female to male ratio of affected patients varies between 5 to 1 to as much as 10 to 1. Adolescence is a transitional phase of growth and development between childhood and adulthood. The World Health Organization defines an adolescent as any person between ages 10 and 19 years. Adolescence is a unique period of rapid biological, social, emotional, and intellectual growth. The psychosocial developmental process can be especially challenging for adolescents with chronic rheumatic diseases, as they are encouraged on the one hand to achieve self-care and independence, but yet this potentially causes conflict between the teens, their parents, and even their providers. Many teens exhibit the impulsive decision-making of childhood, while experimenting with risky behaviors and not adhering to therapy. In terms of early childbearing in Jamaica, a survey done by UNICEF in 2011, in which women between the ages of 20 and 24 years were interviewed, revealed that 15% reported having given birth prior to the age of 18 years. We all know that teenage pregnancy has its own complications. There is an increased risk for premature delivery, low birth weight, small for gestational age, and even neonatal deaths. And this is as compared to mothers aged 20 to 24 years. Pregnant adolescents are also more likely than adult women to be poor, unmarried, to receive late or no prenatal care, and to have low levels of education. They are also more likely to experience negative social outcomes, including school dropout. In terms of systemic lupus erythematosus, there are several risk factors which can lead to adverse pregnancy outcomes. Active or flaring SLE is associated with an odds ratio of 12.7 for preeclampsia and eclampsia. Active nephritis is associated with an odds ratio of 5.3 for any adverse maternal outcome. Hypertension is associated with an odds ratio of up to 7.3 for preeclampsia. Use of glucocorticoids, especially at maintenance doses for adults greater than or equal to 10 to 20 milligrams per day of prednisone equivalent, is associated with an odds ratio of 3.5 for preterm birth. And the presence of antiphospholipid antibodies increases the risk of fetal loss. And in this case, lupus anticoagulant carries a greater risk than anticardiolipin antibodies. Hydroxychloroquine, on the other hand, is protective. And so in patients who discontinue hydroxychloroquine, there is an increased risk for SLE exacerbations during pregnancy. Now for the association between SLE and teen pregnancy. Young women and adolescents are at increased risk of unintended pregnancy as compared to older women. And it has been shown that the sexual behavior of adolescents with chronic health conditions is no different from that of their peers without chronic conditions. Furthermore, most women with SLE will have normal fertility. So when all of this is considered, we realize that sexually active adolescent girls with lupus are therefore at the same risk of unintended pregnancy as their healthy, sexually active peers. Furthermore, there is an increased incidence of renal involvement among adolescents with SLE as compared to adults with SLE, and this will put the adolescent at greater risk of poor obstetric outcomes if they should become pregnant. Pediatric patients with SLE are often on teratogenic or cytotoxic medications, which are contraindicated during pregnancy. And so if an unplanned pregnancy should arise, the teen is typically advised to stop these medications to decrease the risk of the developing fetus. Unfortunately, discontinuation of medicines and or pregnancy itself can cause lupus flares. SLE in adolescents and young adults aged 14 to 21 years has been shown to be associated with an increased risk of preeclampsia and eclampsia, odds ratio 3.2, maternal death, odds ratio as high as 80, preterm birth, odds ratio 2.7, spontaneous abortion, odds ratio 5.1, and induced abortion, odds ratio 30. The rheumatology clinic visit represents an important opportunity to effectively screen, counsel, and promote good reproductive health to prevent adverse pregnancy outcomes in these patients. There is a study from 2020 by Karen Dang et al. In which they conducted focus group discussions with 20 adolescents and young adults with pediatric rheumatic diseases, as well as 7 parents. And from these surveys, they actually realized that the group considered that they were being given directives without explanation. And specifically, they were saying that their rheumatology providers would advise them to avoid pregnancy while taking teratogenic medications. However, they felt that they were getting little other information about the relationship between their rheumatic disease and pregnancy, and no further discussion on pregnancy prevention. The American Academy of Pediatrics, as well as the American Medical Association, both recommend yearly screening of adolescent sexual. It's important that we confirm that patients still understand what is going on as they get older and can think about pregnancy in more concrete terms and know the actual side effects. A useful way to approach the adolescent health interview is to use the HEADS approach. HEADS is actually an acronym that refers to H for home environment, E for education and employment, A for activity, D for drugs, S for sexuality, S also for suicidality, sadness, self-image, and the final S for safety. There are few ground rules, however, for the HEADS approach, and I like to think of this as the Vegas rule. what is discussed between teen and doctor stays between teen and doctor. And this actually needs to be stated explicitly. It's told to the parent in front of the teen before the parent is asked to exit the room. But there is a stipulation. This is that if there is anything that comes up in that interview that suggests that there is harm to the teen or harm to others, then that information would have to be divulged to the parent and possibly to other persons. And again, both parent and child are told this. So looking at the HEADS approach, I'll focus on sexuality based on our talk on reproductive health. So questions such as, are you attracted to boys, girls, or both? Are you seeing anyone at the moment? Have you ever kissed anyone? Or have you ever had sex? Do you know about contraception? And are you using any contraception presently? Of course, the questions that you ask will be tailored based on the previous answers that you've gotten. And even though I've spoken about sexuality in isolation, this should never be done in isolation. It is in fact a good idea to follow the HEADS template in the same order that is presented. Because when you start out with discussing home or education, employment, it allows you to build rapport with the teen. And these, of course, would be less sensitive topics that can allow them to at least be comfortable answering before you get to the more sensitive topics. So again, from the Caranding survey, reproductive health topics that came up as important to the adolescents and their families included, one, the ability to bear children. And so they were concerned about would the medication or the disease affect their fertility. What about their physical ability to have sex and or safely carry and deliver babies? They were also concerned about the interaction between disease, medications, and maternal outcomes, such as the ability to continue medications during a pregnancy and the risk of flares. They were concerned about the interaction between disease, medications, and fetal outcomes. So would the offspring inherit their disease? What about the length of time to wash out medications? Would the fetus end up with birth defects? These are some of the concerns. They also thought it was important to be educated about safe, effective contraception and wanted to know about routine reproductive health care, including obtaining the HPV vaccine. They also had questions, thoughts about how to take care of a child, including recognizing the need for a supportive partner to share the load. So in terms of reproductive considerations of immunosuppressive drugs, we see where it can affect your body image, it can affect fertility, gonadal toxicity, there can be effects on teratogenicity, and there can be other adverse pregnancy outcomes, including miscarriages and preterm birth. So in terms of potential harm, corticosteroids has negative effects on appearance and body image. So specifically, features like acne, hirsutism, striae, weight gain, even short stature. I will comment, though, that for short stature, the main concern is when it is given to young children who are receiving prolonged therapy in doses equivalent to 3 milligrams per day or more. This risk increases with higher doses. Based on societal biases, however, this is often more a concern for males than for females. Nonetheless, corticosteroids can lower self-esteem and negatively affect the prospects of the individual for dating. Other effects of corticosteroids include increased rates of cleft palate, cataract, fetal loss, and fetal growth restriction. Having said that, the risk for oral clefts is small. The odds ratio is 3.3. And when one considers that the population risk at baseline is 1 in 1,000 births, then this has increased to probably 3 or 4 in 1,000 births. On the whole, corticosteroids are not thought to increase the risk of congenital abnormalities noticeably in humans. In terms of its potential to cause neonatal cataracts and adrenal suppression, though this is certainly possible with high doses, this is a rare complication. Now to look at mycophenolate mofetil. In animal studies, mycophenolate mofetil can cause developmental abnormalities, and in humans it causes major fetal abnormalities which include facial clefts and ear anomalies. It has also been shown in drug company files that it can cause miscarriages. MMF is contraindicated during pregnancy and should be stopped at least 6 weeks before a planned pregnancy. Now turning our attention to methotrexate. This is a methyl derivative of the folate antagonist aminopterin. Active metabolites of methotrexate remain in cells or tissues for several months after the cessation of therapy. It is a well-known abortifacient, which is often utilized to treat ectopic pregnancy. Methotrexate has also caused severe congenital malformations, and this is related to its antifolate effect. So closure of the neural tube takes place around postconceptional age week 5. The embryo is therefore probably most vulnerable to the antifolate drugs at this time. And specifically, the sort of sequelae could be central nervous system malformations, cranial ossification, abnormalities of the limbs, abnormalities of the palate, as well as growth retardation. Methotrexate is contraindicated during pregnancy and should be withdrawn prophylactically 3 months before a planned pregnancy. Having said that, for men exposed to methotrexate before conception, no reports of adverse pregnancy outcomes have been demonstrated. Now looking at cyclophosphamide. This is an alkylating agent reserved for the most severe and life-threatening symptoms of SLE. And this is because of the risk of toxicities, including infertility, including infections, as well as a long-term risk of cancer. Cyclophosphamide is teratogenic in all animal species, and in humans has been shown to cause defects of the calvaria, anomalies of craniofacial structures, including the palate, ears, and eyes, abnormalities of limbs and visceral organs, as well as growth retardation and developmental delay during childhood. And this is when cyclophosphamide is administered in the first trimester. It is, however, unpredictable because it does not always cause malformations when given during the first trimester. For cyclophosphamide that is given in the second and third trimester, it will not result in structural abnormalities, but can still cause growth restriction, impair neurological development, and suppress hematopoiesis in the infant. Cyclophosphamide is gonadotrophic in both women and men, depending on the cumulative dose and the age of the patient. So the stage of sexual maturation is crucial to inducing gonadal dysfunction in females. The further beyond puberty, the greater the chance of infertility with an equivalent dose of cyclophosphamide. In women, sustained amenorrhea after a total dose of 3.5 to 7 grams of cyclophosphamide was rare under the age of 25. However, between the ages of 26 to 30, there was a rate of 12%, and for patients who were older, 31 years and older, the rate had increased to 25%. In males, on the other hand, gonadotoxicity of cyclophosphamide is present even before puberty. Intravenous cyclophosphamide therapy should be started only after negative pregnancy tests. There should be attempts made to preserve the fertility of the patient. Safe contraception should be instituted, and attempts at conception should be delayed until 3 months after the cessation of therapy. Again, rituximab, there is potential harm. There was one particular study that looked at the rituximab global drug safety database, and it found several things, but overall, of 90 live births, it only found about 4 neonatal infections, 2 congenital abnormalities. There was 1 maternal death related to the pre-existing disease. However, the authors concluded that although there were few congenital malformations or neonatal infections seen in exposed neonates, women should be counseled to avoid pregnancy for at least 12 weeks after rituximab exposure. And the European League Against Rheumatism, EULAR, recommends that rituximab be replaced before conception by a pregnancy-compatible drug whenever possible. Finally, we will look at belimumab. Only a few case reports on pregnancy outcomes with belimumab exposure, and none of these support a specific pattern of birth defects. Nonetheless, EULAR again recommends that belimumab should be replaced before conception by a pregnancy-compatible drug whenever possible, and can only be used during pregnancy if there's no other pregnancy-compatible drug that can effectively control maternal disease. So what are the drugs that are safe to use in pregnancy? Hydroxychloroquine. There have been no increases noted in congenital malformations or cardiac conduction disturbances, no visual abnormalities, no hearing abnormalities seen with hydroxychloroquine. Azathioprine. Even though azathioprine potentially can cause significant malformations and has been shown to do so in animal studies, for the fetal liver, it lacks the enzyme inosinate pyrophosphorylase. And this is important to convert azathioprine to its active form. As a result of this, the human fetus is theoretically protected from azathioprine, which has crossed the placenta. Cyclosporin A is not toxic to the exposed fetuses at a maternal dose of 10 milligrams per kilo per day. However, at higher doses, it can be embryotoxic. The recommendation is that cyclosporin A can be maintained in pregnancy at the lowest effective dose. Tacrolimus also can be maintained during pregnancy at the lowest possible effective dose. However, it has been shown that in up to 50% of babies, they can be born preterm or premature. Intravenous immunoglobulin, IVIG, there are no fetal adverse effects, and it has been shown that those neonates have normal percentages of T cells, B cells, natural killer cells, and monocytes. So looking at preservation of fertility, these methods should be considered for all menstruating women with SLE who are going to receive alkylating agents, specifically cyclophosphamide. The most extensively studied method for prevention of premature ovarian failure involves the use of gonadotropin-releasing hormone analogs. They have been shown to have a good safety and efficacy profile. Gonadotropin-releasing hormone analogs are shown to protect against premature ovarian failure, but there are no data on subsequent pregnancies in these patients. The patients can also develop menopause-like symptoms. Thankfully, these are fully reversible upon discontinuation of the medication. In a study in childhood onset patients with SLE under the age of 21, it was suggested that gonadotropin-releasing hormone should be administered 22 days before cyclophosphamide is started or continued. However, the recommendation is still to start it prior to or concomitant to initiating the alkylating agent. Other options include oocyte or ovarian tissue cryopreservation, as well as cryopreservation of sperm and sperm banking. Just to say that these are options that are available in Jamaica, but they are quite expensive, going in the order of US $6,500. So in terms of reproductive health and contraception, practitioners should emphasize the importance of protection against sexually transmitted diseases and unplanned pregnancy. And it is important to weigh individual risk factors when counseling the patient. Looking at barrier methods, male and female condoms, we know that if used consistently and correctly, they protect against both pregnancy and transmission of STIs. However, for adolescents, consistent condom use is rare. One study actually showed that less than 40% of sexually active male and female respondents under the age of 20 reported using condoms at the last intercourse. The first year typical use contraceptive failure rate of male condoms is about 15%, and it goes up to 21% for female condoms. This is unacceptable in a high-risk population. Other barrier methods such as diaphragm and cervical cap do not protect against STIs, and they also have an unacceptably high typical use failure rate, as much as 31%. So in conclusion though, what we should recommend is consistent condom use by sexually active patients to prevent STIs. However, a second contraceptive method should also be recommended for highly effective pregnancy protection. Looking briefly at the oral contraceptive pill, in women who have positive antiphospholipids, whether they've had antiphospholipid syndrome or not, contraception with combined hormones should be discouraged. Similarly, women who have had myocardial infarction or ischemic stroke and positive lupus anticoagulant, the combined pill will increase the risk of arterial events. And so in these patients, it would be recommended that they take a progestin-only pill. Nonetheless, the progestin-only pill should still be weighed against the risk of thrombosis if that is being considered as a contraceptive method. Among adolescents, there is poor compliance because of in use of the oral contraceptive, and up to 20 to 30% of adolescents will miss at least one pill per month. Furthermore, the progestin-only oral contraceptive must be taken at the same time every day to maximize efficacy. And this does raise concerns about adherence in adolescents. Other hormonal contraception include depo-medroxyprogesterone acetate, as well as Implanon. You can also consider use of the intrauterine device, and this can be offered to all patients unless there is a gynecological contraindication. It's highly effective, long-lasting, easily reversible. Options include the copper IUD, as well as a levonorgestrel-releasing intrauterine system. In terms of emergency contraception, the adolescent should be aware that this is an option if unprotected sex occurs, either because of contraceptive non-use or method failure. And in fact, the American College of Obstetrics and Gynecology recommends that emergency contraception should be made available to all women, including those who have contraindications to oral contraceptive pills. And overall, they found that it has been pretty safe. So finally, we will just discuss human papillomavirus. This is the most common sexually transmitted infection. It's also the cause of most anogenital cancers. Cervical cancer, which is caused by HPV, is the second most common cancer in Jamaican women. About 90% of HPV infections spontaneously resolve over 3 years, but there's a 10% which remain as persistent infection. That is, the virus is repeatedly detected in cervical samples. As HPV is controlled by local and systemic immune responses, individuals such as patients with SLE who are immunosuppressed are at increased risk of HPV persistence and therefore at increased risk for cervical cancer. As a result, we should be promoting HPV vaccination in all our patients. Of note, it is not a live vaccine, and so there is no contraindication because the patient is immunocompromised. Furthermore, in our local setting, the Ministry of Health and Wellness of Jamaica offers HPV vaccine free of cost to girls between the ages of 11 to 13 years. HPV seroconversion rates may be low in patients who are taking steroids and immunosuppressive agents, so something to bear in mind. And there have been reports of venous thromboembolic events in association with the quadrivalent HPV vaccine. However, the rate is about 0.2 per 100,000 doses vaccines administered. Essentially, though, the EULAR recommendation is that HPV vaccination should be offered to young women with stable or inactive SLE and/or antiphospholipid syndrome according to local protocols. Particular caution, however, should be applied to those who have a high-risk antiphospholipid profile. So in summary, our take-home points: 1. Pregnancy in adolescents with SLE is a combined risk for adverse maternal and fetal outcomes. 2. Yearly screening of adolescent sexual health is strongly recommended. Think heads. 3. Potential negative effects of selected immunosuppressive drugs on body image, fertility, and pregnancy outcomes should be discussed with patients. 4. Consider fertility preservation methods for all menstruating women with SLE who are going to receive alkylating agents. 5. Contraceptive options should be discussed with sexually active adolescents with SLE, and dual contraception is recommended. And finally, 6. HPV vaccination should be offered to young women with stable or inactive SLE, with caution in those with high-risk antiphospholipid profile. Thank you for your attention.
Thank you very much, Dr. Scott, for that very encompassing talk on the child and adolescent with lupus. So we would like to field some questions from the audience, both live and online. Any questions? Any online questions? All right, I'll start with the first question. Dr. Thompson, the male reproductive health of a patient is very important and very much, I believe, is not adequately addressed when we see our patients. I think from the earlier morning session we spoke about, Dr. Klaus spoke about trying to incorporate some of these questions into our history. And one of those questions sometimes can be very embarrassing, I want to use the word, is the erectile dysfunction issue. How can we overcome that as professionals to just brace the topic? Because sometimes the patient comes with their significant other. So how do we approach that?
All right. I think it is going to be dependent on the relationship that you have developed with the patient. I think over the years what I've learned is that, you know, trust is something that patients really, they don't give it freely, so it has to be developed. And you really have to read the room with regards to the patients and with regards to who they come with. Now, I've had some interesting times in my office with regards to that discussion. But you have to be able to read the room and know how to broach the topic. Now, if the patient is there by himself, I mean, it's simple. I don't think it's the first question that you're going to ask off the bat. But you have to develop some rapport and some amount of trust before delving into other areas. I think by nature, patients will expect me to ask those questions because I'm a urologist, so they come anticipating that I'm going to do certain things to them. And to date, I know there's this thing about really with rectal examinations and prostate examinations. I'm yet to face in practice a person who has been, you know, I can't convince them then to do a prostate exam. Maybe one person, but you know, once you talk to them and you tell them the importance and that there is help available, I think that is part of the issue. When persons don't think that there is help available, they will tend to be withdrawn and not want to tell you about their sexual dysfunction. A lot of men think that there is no help available for sexual dysfunction. So that's part of the problem. So we have to break down a lot of barriers before we can get to the root cause why the discussion is so difficult.
Very good point, very good point. Any further questions from the audience or online? No? All right, we're going to go straight into our next session. We'd like to thank Dr. Thompson and Dr. Peter Gay Scott for their contribution today. Let's give them a round of applause. Mr. Chairperson.
Thank you very much, Dr. Scott and Thompson, and moderator, Dr. Lou Jones. Before we move on to the next session quickly, I just want again to big up our sponsors, the National Health Fund, Wisynco, Co-Create, IPCA, Jamaica National, Flow Foundation, out the Channel, Concepts, TAC Printers, Axel, Spa, Aesthetique, and Ophthalmic Suites, Realism, and Image Nation. We thank you sincerely. We're going to just have a little bit of tokens. Yeah. We'll just ask Dr. Lou Jones to come forward. Marianne Banks, yes. Mm-hmm.
Token for that very interesting and enlightening talk.
Can I just ask, Miss Allen, you stood up about your birthday, right? We want to give you a little token. Dr. Tollereed? Where's Dr. Tollereed? Can we give our birthday lady something? Something's coming up. Okay, and this is with the compliments of
Of Star Aesthetique.
Okay, very nice. Yes. Enjoy.
Happy birthday. I hope you enjoy your birthday treat. Miss Allen is one of our faithful volunteers.
I know, yes.
So we're just so happy to let her celebrate her birthday with
It's
us.
nice that you could celebrate. Thank you so much. Any couples celebrating anniversary? I see. Any couples? What are the couples here? Oh yes, that's the Prendergast, right? Yes. Boy, you're at all of the lupus events, right? Prendergast, right? Dr. Tollereed would like to present a little token again. Yes, so and any actual anniversary celebration around now? Any wedding? None? Okay. Okay. The couple Prendergast? We have 4 couples, right? Okay. Mr. Prendergast? It's all about sharing, you know? It's all about sharing and lifting up each other, right? No, it's okay. She has all her mess.
My lupus one. Take a time. Put a picture. Oh, we don't need it for the. Thank you very much. COVID protocol.
Thank you very much.
By yourself, you said to us.
And the other couple that we have? Oh, yes. Yes. Two couples. 3 couples? Wow. Okay, yes, yes, yeah. It's unexpected, but it's nice, right?
Nice to have you, Doctor.
Yeah. Thank you. Compliments of Caribbean Dreams, all the tea you've been having. And there's the last 2.
No, one more. Yes, the last 2 couples.
Oh, well,
Yes.
separate couples. Right, okay. Represented, right? Okay.
Thank you.
Okay. And Mhm. Yeah.
Thank you. That's it.
Yeah, it's just nice to spend the Sunday together, right? You know, the sharing and lifting up each other's lupus warriors and the volunteers. You know, there's a beautiful story, true story, at the Special Olympic Games in Seattle several years ago. The youngsters, mentally challenged and physical challenged, they lined up for the start of the 100-meter race. Remember, these persons are mentally and physically challenged. So the race got underway. So when the race got underway, they started to run these special kids. One little boy fell and he tumbled over 3 times. And the others were a little out front, and this little girl with Down syndrome disease, she turned back, stopped running, and went and kissed the little boy and said, "That will help you." The other 7 or the 8 special athletes came back, lifted up the little boy, and all of them walked to the finish line together. And that happened in Seattle, Washington. So it shows the interconnectedness of humanity. It shows that the ultimate goal of mankind is to invest in your fellow human beings. And the blessings that we receive are not meant to stay with us. The rivers flow and give us what we need. The sun doesn't shine on itself. The trees don't eat their own fruits. So as human beings and as a part of the human race, we have to ensure that we pass on our blessings to each other. At this time, I'd just like to invite our moderator, Dr. Rheumatologist. Not quite, sorry. I was looking at Stacy. Dr. McLeod. To the dermatologist, right, yes. Floor is yours. Thank you.
Thank you. Right, thank you all for staying with us. We know it's been a little bit long. And so without further ado, we're going to get right into it. So in this session, we're going to shift focus a little bit. And we're going to focus on life with lupus. We'll be hearing from our patient perspectives and other experts. We had hoped to hear the voices of some of our lupus warriors in a short film, but unfortunately this is not yet available, but will be posted to the Lupus Foundations of Jamaica's YouTube page, so check that out. So we'll be moving right into our panel discussion, and we will be hearing from this panel of experts as they discuss relationships and sexuality in lupus. Our panel will be led by Dr. Karen Carpenter, who is eminently qualified to do so. Dr. Carpenter is the head of the Institute for Gender and Development Studies at Mona Unit. She's a Florida-based certified clinical sexologist. That sounds interesting, doesn't it? With a PhD in educational psychology. She's also the director of the CSRG Sexology Clinic at the University Hospital of the West Indies. She's the editor of Interweaving Tapestries of Sexuality and Culture, author of Love and Sex, The Basics and Questioning Caribbean Jewish Identity, and co-author of Language, Race, and the Global Jamaican. Dr. Carpenter is the host of Love and Sex on Facebook and YouTube. Her research interests include human sexuality, gender, and interpersonal relationships, and psycholinguistics. Wow. Next, we have our own Dr. Stacy Davis, who is a consultant rheumatologist and the past president of the Lupus Foundation of Jamaica. She's also the secretary of the Caribbean Association of Rheumatologists. To broaden our perspective of our panel, we have the Reverend Nielsen Waite. He's a lecturer in the Practical Theology Department of the United Theological College of the West Indies. He's the chaplain of UWI Mona campus, author of 8 books on counseling and the Caribbean family. He's a volunteer counselor with the Lupus Foundation of Jamaica, and he's been a minister of religion for 40 years, and he's also a marriage and family counselor. Yes, we have experts. Our next panelists are also experts in their own right, by virtue of their lived experience with lupus. Kiana Jackson is a poet, author. I missed him, but I'll get back to him. He's a proud lupus warrior and student of the Edna Manley College of the Visual and Performing Arts, where she's pursuing her degree in the Bachelor of Arts in Drama in Education. Kiana discovered her love for drama at a tender age, she says, and has used it to overcome her struggles as a teenager, and now intends to develop her talent and also to use her platform to help others. And she has already begun to do so. She's currently the communication director of the Remarkable Arts Company, youth spokesperson for the Lupus Foundation of Jamaica, a charter member and vice president of the Edna Manley College Optimist Club. And last but not least, we have Mr. Jerome Noble. He's an entrepreneur and a medical missionary who has been giving moral and emotional support to his wife, who's been living with lupus for over 22 years. So indeed, we have a lovely panel here, experts in many areas, and give them a round of applause and let the discussion begin. I turn over to Dr. Carpenter.
I believe there we go. Now we're live. Makes a difference. Good afternoon. Thank you for having me here, and thank you for assembling such an amazing panel. I feel very honored to be able to interrogate all of you. Today we're going to move the conversation a little bit towards sexuality, relationships, and the interpersonal. Often when we speak about challenges of health, we keep it very, very medical, and we lose the human being in the process. We lose the person who is both affected and the person who is with that person sharing the journey. So I'm hoping that our panel can bring that expertise. As a very young intern, 20 plus years ago, when I was doing my first set of cases, I landed with my first case being a female of 36 years old who had gone into medical menopause. And you know, if you hear medical and menopause, it means that it's not a natural menopause. At 36, she was in menopause because she had had a full hysterectomy. And what struck me as a very young intern under supervision was that the missing link in that care process, in that discussion, in the many visits to me and to her doctor, was the partner. It struck me how little we speak to the partner who is experiencing the situation alongside the patient. And it struck me how little we explain to men about women's gynecology, women's reproductive system, women's challenges as a physical self and an emotional self. And much of what I had to do with that very, very first internship was to help the gentleman understand what his wife was going through, because the doctors were not including him in the room when they were speaking to his wife. So I'm saying that as a call to action, I'm encouraging you to remember there's a partner often in the situation, and they need to be included in the discussion. The patient is the person in your primary care, but they're not doing it alone. And the translation sometimes gets muddled when they are emotionally involved and they're trying to tell the partner what they should know. So I'm encouraging you to do that. I'm going to ask each of our panelists today to answer one of the 4 areas that I've selected. Well, yes, I can count. One of the 4 areas that I selected from the program. And I'm going to start with Dr. Stacey Davis. And Dr. Stacey, since we're moving from reproductive health into sexuality, intimacy, and partnering, I'm going to ask you to deal with that question first. What has been your experience of patients coping with infertility and pregnancy loss?
Thank you, Dr. Carpenter. Thank you, Dr. Carpenter, and good afternoon to all of you. Even before I speak on the reproductive health, I'm just going to quickly do an overview as to how we get to the point where our patients have to deal with pregnancy losses. So we know just as how everybody's lupus is unique to that patient, the reproductive health journey for our lupus patients are also unique, and there's not a one-size-fits-all. However, there are going to be similarities because of how the disease affects our patients and the challenges that they experience. And also, unfortunately, drugs that we use with the hope of improving the quality of life of our patients sometimes also adds to their challenges. One of our speakers this morning spoke about reproductive health starting at adolescence and going through to menopause and beyond. And if we look at the journey that our patients experience sexually, they point out a few things along that journey. They talk about in teenage years, they have poor body image and self-esteem due to weight gain, rashes, and scarring. They then have issues in the teenage years and early adult years in terms of dating because of not only the physical issues, but also the mood disorders that occur, both from the illness and from the drugs. And then as they move into dating with the hope of finding a partner and creating families, then we have to look at the effect on actual physical sexual function. We heard about pelvic floor disorders this morning, but not only that. You have arthritis in your hip and your knee. The actual act of sex now becomes not a pleasurable experience and you avoid it. Also, people lose range of motion of those joints. And so even if they want to satisfy their partner, they're limited physically in what they can do. In those who have, intercourse with the anticipation of having children, then we move right into the coping with the pregnancy loss. The expectation of adding to the family and being a parent is, as we heard earlier, quite often not easy for these patients. And in terms of how they cope, the first challenge is this. When we lose our loved ones, very often it is visible to others around us, and so we get support from others. Pregnancy losses tend to be a more private issue. It's not something that we go around and discuss. And so it's almost like an invisible loss to the patient. It's something that they have to walk through, maybe with their spouse, because he too was expecting to become a parent, or she too. And also, the things we do to try and heal and move on, the services we have, the gatherings we have, we don't tend to do those things when it comes to the loss of a fetus. And so in coping, the patient now is left to try and understand with the spouse and maybe other children that may be in the home, how to deal with it by themselves. And it really means that they have to learn, one, that they're not alone. Because one of the things patients need to understand is especially early pregnancy losses are quite common. But because we don't speak about them, they feel so isolated and feel as if they alone are experiencing this devastating issue in their life. Also, in terms of infertility, one of the best ways to deal with it is to have communication with your doctor. An understanding of what are the factors that cause infertility will help you to overcome these issues. And especially if you have already suffered a loss already, to prevent a second loss, walking through and understanding that medications have to be adjusted, understanding the importance of a healthy diet and moderate exercise, understanding the impact of good rest is very important, and understanding that there is help, because you can get online resources for where you talk with persons who have also experienced a loss, who are also having infertility, because nobody knows what we feel except for somebody who is going through it also. So these are some of the considerations that patients can look into when they're going through these concerns.
Some very relevant issues, and I'm happy that you've moved the conversation right into the sexuality conversation and the issue of the hidden loss of a pregnancy that didn't go to term. Many times no one else knows except the couple and perhaps a parent or other close relative. Thank you. I want to ask Reverend Nielsen, with his vast 40 years of experience, to assist us in understanding a little bit about whether or not or how an intimate relationship can be both a resource and is it ever a burden. So I don't know if you have a mic with you, Rev? That one is turning on. Right. Just turn it on. If not.
Thank you, Dr. Carpenter. I listening to Dr. Stacy now, and I just said if I was the spouse of a lupus patient, after hearing some of the challenges, the physical challenges that the patient will have with regard to, in terms of dealing with the whole business of physical sex, then you may be turned off. But then you come to the fact from the acknowledging that people have needs and being able to communicate those needs and to feel that you are a person of worth, notwithstanding the challenges that were mentioned. And how can you communicate to a partner who may not fully understand? And I think that's the challenge that you see. Because one, you're coming into the situation with your views of sex and sexuality, and it goes back to family of origin, how you were taught about sex and sexuality, and now you have a physical challenge, and it is a psychological and emotional challenge as well, but yet you still have needs, and therefore, and those will vacillate, and they will be here today, and how can you communicate with a partner because you feel that you need some person in your life? You don't want to be on your own in terms of dealing with all the challenges that the illness presents. And so therefore, what I've found is that persons want to have a partner, but then they ask themselves, would my partner understand that I can't be actively engaged with them all the time? Or would they be with me, or would they be looking outside of this relationship? And I think that is a primary concern in terms of being able to sit with some person. And as you said at the very beginning, if you had a partner involved in the process in terms of communicating with each other, I think that is primary in terms of helping the couple to know where they can go, what are the shortcomings and where are the strengths, and how they can create for themselves a unique relationship where they can meet each other's needs. And I think, and it has to do, you have to deal with those issues of sexuality in terms of how you were taught about sex and sexuality. You have to debunk some of those, and you have to help persons to grow outside of some of those issues that, that will not help them in this relationship. And I think, so that education and that that conversation in terms of growing with each other and helping each other and communicating with each other in terms of needs that both persons have. I think here's where you need to begin if you're going to be effective in terms of recognizing that you can have an effective relationship, notwithstanding the challenges.
And Rev, what I hear you emphasizing is some psychosexual education, that your role as someone who's doing that pastoral and counseling work to help your patients, your clients, understand that even the information they have from childhood, adolescence, etc., is not sufficient to deal with the relationship that they want to have now, which is both intimate and erotic and romantic, as opposed to simply companionate, which we can get from others. Thank you for that, Rev. And no better person to speak on the intimate relationship than the person who's had it themselves. Sir Noble, how are you? Mr. Noble is a spouse of the charming lady you see over there. They have a 15-year-old daughter, I discovered. I dug into their business a little bit. Thank you for sharing that with me. And they've been together some 20-plus years, yes?
Yes, that's correct, and
All right,
thank
so
you.
tell me, you've been going the distance, both of you, because you're not doing it alone. What are the secrets in your relationship to keeping it alive and getting to the place where we're seeing you both here today?
First of all, I have to have experience, patience, and the level of communication and listening, because with lupus patients, they are very emotional, and they need time for you to listen to them, to their pain and what they are experiencing and what they are going through. For my wife, she has systemic lupus. The lupus that she has affects both her skin and her organs. So, you know, she get a double whopper. So I have to be everything for her. A doctor, a plumber, I have to be everything for her. Every cry she has. Sometimes lupus affects her so much, she cannot even see sometimes. And sometimes it appears if she's losing her mind. And I have to be so patient with her and say, don't worry yourself, man. Sometimes I can't see myself. Come along with me and take her patiently. And as it relates to the discussion sexually, sometimes the urges is there and she's not ready. But I will be exercising that level of patience to wait. And the good thing about it, I realize that women, their night begins in the morning. So it's how you treat your spouse in the morning show you the benefits that you get in the night. So, you know, I do everything for her, breakfast in bed and the whole cleaning. You know, I'm like a whirlwind. I clean the place, bathroom, ceiling, everything. You know, so, and not only that, when I realized that she has contracted this lupus, I realized that this is a new normal and I need a new start. So for me to be that secret for my family and be resilient, I started a new start with her and with the family. And New Start is an acronym. N is for nutrition. So, you know, at the time, I was a vegetarian, and she was a meatarian. So, you know, so two pot have to cook. So I have to be cooking the vegetarian, and I have to cook in the chicken. After a while, it becomes burdensome. And I shift over now to eat chicken. So gone back to the meeting over the years now. Compromise, because in a relationship, you have to compromise, 50-50. You understand? So I decided that I'm going to compromise and start to eat meat. And over time, and I realized that it is still taking a toll on her health. Within the 22 years, she was hospitalized 3 times. And she come right down to zombie. When you look at her face, you know, you're frightened, you want to cry, but you can't cry in front of her. I could not cry. I have to be, you know, brave and bold. And the rest of family members, some stand off. I said, no, man. Co-worker were very supportive. And when sometimes if she take a medication that affects her, and it don't agree with her body, and the co-worker call and say, excited. I said, no, calm down. She will get over it. And they were wondering, oh, you're dealing with it. So I have to become a counselor as well. Right? So with that nutrition thing, changing diet. Right? The way we eat. And over time, I eventually come after the meat. And then employ her to cut out the meat as well. And so now we start seeing a great change and a lot of green juice. And going the extra mile. When she's at bed, I'm up in the night with my juice extractor, doing carrot, beetroot, celery, cucumber, and callaloo, all 5 together, and extract that juice and wake her up. And I said, drink her because I don't want the thing that is in it to expire. And she drink that. We pray, you know, with everything you have to have God in it, you know. We pray over it and give her to drink. And after a while, realize the skin begin to be very clean. And she begin to be very relaxed. And early in the morning, I remember I gave her some color with cucumber. But I realized in the morning, it make me, because whatever I give her, I take it for myself. But I realize I get dizzy. And she get dizzy. So we say, all right, well, let's change approach. If we have color alone, it gets us dizzy. So let us have it at night when you're retiring to bed. So we do that, and believe you me, the juices help her, give her that level of energy and stability to go on. And then now, the second one in the acronym, you start exercise. Just simple exercise, just walking, and realize that it helps the entire body. And then I encourage her to drink water. We drink the W, right, the W, right, the W of the acronym. So 8 glasses of water or 2 of the long one, we drink every day because we know that the brain takes water. And sometimes she does get dizzy. And I told her, I have to act it out sometimes. I said, just bend over a little bit because oxygen is loose on the brain. So you have to pull from the kneecap. So spend 5 minutes, bend like this. And then the water go back to the brain to oxygenate the brain. So as I said before, I have to be a doctor, everybody, right? And then as now for sunlight, take her out into the sun, 45 minutes, because sometimes she's experiencing every flow of menstrual, and it's painful. And I learned that if the women in the sun, vitamin D for 45 minutes to an hour, it reduces the heavy flow, and it reduces the pain in the menstrual monthly cycle. And now T, temperate. Have to be temperate in everything, right? What we do. And then moving on, A, I told her early morning, we need the fresh air because the fresh air oxygenates the blood. And and not only that, the fresh air decreases depression and anxiety. And with lupus patients, they're always depressed. They watch a movie, they get depressed. A friend call and give a bad news, they get depressed. But right, so with her now, thank you, I know that we're pressed for time. So with her now, I encourage her, we have to go to bed before 9 or 10 o'clock, because at 9 o'clock, the immune system is being reboosted. 10 o'clock, melatonin is formed. Melatonin is where new cells are rebuilt in the body. Go from 10 to 2. So I realize that we all need that rest. And then finally, T, trust in God. And I encourage her to trust in God with all her heart and lead not unto her own understanding.
I think that's an acronym that we're going to remember, and I thank you for that. I'm not so sure about the medicine, and I'm not going to ask Dr. Rivera's medical plan, but amazing and wonderful that you've come on the journey together. And your temperament, certainly, is part of what has made you stay the course. So thank you for that. And the lovely Kiana, you're next. We want to hear from the youth, not just the young at heart like Mr. Noble. We want to hear from the actual young people. Tell me, what would you say, 3 things you would say to another teenager about dating with lupus? And I particularly have a question for you, Kiana. Disclosure. When do you tell someone who's interested in dating the beautiful Kiana? All right.
Okay, good afternoon, everyone. All right, so firstly, what I want to speak about is socialization. A lot of persons don't know about lupus, and what I've found is that people tend to fear what they do not understand, and what they don't understand, they tend to destroy. And in these days and times when dating is not the norm, as they would say, there are a lot of different social perspectives and standards now. It's very difficult after finding out that you have been diagnosed with lupus. Some of the reasons that you may not want to tell someone that you have lupus, first of all, some of the reasons that you may not even want to date, is because of the limitations you might have in a relationship. I mean, not being able to communicate, not being able to fully express your feelings. You can't really go nowhere. Like myself here, cannot leave the house at all. Constantly on medications, always swollen face, looking puffy. It's really a lot. So when you do reach that stage in your life that you want to really open up to someone, it's another battle to find someone to open up to, because no one knows about lupus and they tend to not want to understand it. Because I can remember from a personal experience, I told someone that I had lupus, and the first thing they asked me, you can contract it through sex? That was the first question I got, you know, and that drove a lot of fear into me, you know. Not like I don't really have that fear now, but it's because the whole skin, because I used to have really bad skin, you know, and I just accept the fact that it's not all that good, and I started to work on myself. And that is one thing that you have to do before you approach dating. You have to work on yourself for yourself, and not work on yourself so that you can be accepted by someone else. Other things that might actually raise questions, you know, is the risk of not having children. It's why a lot of persons, they don't know the depth of it, but they have that little edge. Nobody wants to deal with the emotional roller coaster, because we are very emotional. I am very emotional. I cry over everything, and I'm not going to lie. And also the complications. As I said, medication every day, the continuous blood tests. Nobody wants to see you getting stick to that needle. Nobody. And then it's that approach that I believe that with lupus, a relationship is not 50-50, but it's 100-100, because both parties have to give their full, all, and everything. And back to your question about when do you tell someone, I think it's the first thing you must do. First thing you do after you find out that you like the person and you really want to court, because young people nowadays, they don't court anymore. They don't court. I'm talking, it's my generation. Courting is not the thing anymore. You do a direct message, and after that, it's magic. Nothing, yeah, so nobody courts anymore. But you know, telling the person, listen, I have lupus, and it's this, and it's that. And then they're going to ask you, what is lupus? I do not want to answer what is lupus. Honestly, I do not, because people don't understand. And yes, you can try to make them understand, but then the ignorance in the process, because telling someone what lupus is one thing than actually showing them. Because people learn by doing. They can say lupus, all right, it's not bad, but then in the process now, it's totally different. So I do encourage, I don't meet a lot of young persons with lupus, but I do encourage them, build fruitful relationships, you know, have those talks that you don't want to have, especially when it comes to sex and being tired all the time. Have those talks, because we're in a generation that is driven by sex and all of that ecstasy.
The reason you're here is sex. So the entire planet is driven by sex.
Yes.
Yes?
Yes.
It's not new. You all didn't discover it. Trust me.
Yeah. Yeah, so
we don't need to say sex is a bad thing. Sex is why we're here.
It's not a bad thing. But while I was growing up, I was told that it was a bad thing until I went out.
From some people who thought it was a good thing, and that's why they produced it.
Yes.
Yes? Okay,
Yes.
I'm going to go. Thank you. And I love your honesty and your frankness, and you're very wise for your years, you know? You've really thought this through. I'm going to encourage you to keep even those little sound bites of information that you share, even when you're annoyed. Keep spreading the word, because that's why people don't know, because no one is talking about it. I want to go back to Rev. Rev, as someone who's a marriage and family counselor, you will have encountered the challenges that are faced, particularly with the lupus population. And I'm speaking about partner challenges now, because I think we focus a lot on the patient, but we ignore the partner. How do you counsel someone who is struggling, and it need not be a man, it could be the woman if the man has lupus, who is struggling with the difference between a companionate relationship of compassion and a romantic sexual relationship that is going to involve rigorous and vigorous sexual encounters. How do you help that person through that?
I need to begin with my brother here. That's a total commitment that he's talking about, and our sister said is 100. 100. Yeah, those. I think there's where you have to go. It's not going to happen overnight, and so therefore you want to be able to, because I think a person going in, you have a relationship, and then you go in and you've been having these physical challenges and you don't know what they are, and then you go and you go to Dr. Stacy, and then you come back and you say to your partner, I think one client said, I just discovered, I'm not sure how I can tell my husband. I'm not going to tell my mother now for a long time because she's going to have a heart attack. And how can I get him now, because we were having some challenges around sex before. Now I have to tell him. And so we have to walk through how we're going to do that. And it is always good if you're able to get the other partner now to hear in terms of what the relationship means to them. Because if they're committed to the relationship, they will be willing to make some sacrifices. And so therefore to work on some stuff. And once you begin to do that, I think it builds the self-confidence in the patient, the person who's been identified, and then it helps the other person to know that it is not a situation where you're not going to be committed to each other. You still want intimacy. You still want to go out. You still want to do stuff together, but you need to be able to exercise the patience that our brother has identified, and I think that is very important.
I'm going to stay with you, Rev, because I think having that experience with so many couples, right? You will understand the subtlety, the nuance between age differences. I noticed that in one of the early panels it talked about age, and another panel talked about gender. Of course, I meant sex, as in biological sex, because gender is 54 to 64 different genders. But does it matter what age that couple is at? For instance, like Kiana, who is a young and vibrant, leaving her teens now, 17-year, right, teen, as opposed to the 25 to 34-year-old, as opposed to the 36 to 40-year-old. Does it differ in terms of how you're going to counsel that couple, that partner of the lupus patient?
A very good question, because I remember having a person who was diagnosed with lupus who was in the 30s, and they decided now they're going to have a partner who was in the 20s. And that was an interesting one, because I said to myself, perhaps they think an older partner would not be as understanding. But if I have this person who is younger, I can train this person. And that's how I saw it. But the challenge came is that when the younger person was getting a little tired of all the training. And I said, do you want me to have a conversation with this younger partner? And the person said, no. I want to continue to train him the way that he's supposed to do in terms of massaging and all the other stuff that he needs to do. But if you were to get in there, he may give you stuff, because he began by doing that in one encounter.
Yes.
And she was surprised that he was complaining.
Yes.
And so, but it could not go any further, because you have to allow for that to happen.
Yeah.
And I think there's where the challenge comes, because some older persons, especially if they've gone with other partners, they will be more impatient.
Yes.
And they will
because they've had other experiences.
Exactly.
And so I find the age group matters tremendously, even more than the condition that the patient has.
Yes.
Because we have patients with conditions across the spectrum, whether it's cancer, whether it's, as I said, hysterectomy was the first one I encountered, all sorts of things. But the age of that couple And the pairing of that 26
Right.
to 30 odd, very, very different. Doc, I'm going to come back to you. Here, Rev is saying, you know, maybe they come to you, they get a diagnosis, and then they get in a Columbus spirit hits them. They want to discover new nations and all sorts of things and train people into their way of being. But do you ever ask to see both partners in a relationship when you give a diagnosis?
And the truth is, not under normal circumstances, but certainly, and that's because very often time limitation in a visit, but certainly if a patient brings to me a concern that is directly impacting the partner or the family as a whole, I will ask to meet with them as a group, or I would either refer them to a psychologist who may have a little bit of a better understanding of how to manage the situation. But yes, there will be instances once something has been brought up that we certainly want the partner to be involved, because we know that when one person is sick, the family is sick. It's not just the individual. It affects everybody in that unit. And so to get your patient better, the unit also needs to be better and understand everything that's going on.
And, you know, I have another question, but I'm going to give it to Kiwana, although I could stay with Rev all day, you know, you see. When you have two people who counsel, it's hard. We could have conversations for the next week, but I want to ask you, when the other person, you're interested in someone, they are interested in you, let's say you even start dating, and when that person indicates to you that their sexuality, their sex drive, their libido, their arousal point is higher than you would be able to manage through whatever means. I mean, they could also be boasting. And we know that sometimes they exaggerate. Yes, like big fish. They caught a fish this size. Okay, so they could be exaggerating, but in any event, if they indicate to you that their sex drive is much higher than you would normally enjoy, what's the way to deal with that? And I'm speaking for anybody in your age group, not just yourself.
Well, the way to deal with that is communication, understanding, because you can communicate and not understand, and also compromising. If that person is willing to tone it down a bit, then of course, but then you have to understand that you have limits. And even if that's not your real limit and you can go up further, it's compromising on both sides. So if the person is not willing to deal with you, then it's a total no-no for me, because that means I'm going to feel insecure as if I can't satisfy you. Yeah, so to avoid that, as well as other stuff you're dealing with, just leave it alone. It's not one fish in the sea.
Is there stay with it, stay with it, stay with it. Is there a threshold? Is there a point at which, like, you have your boundary where you say, once a person is doing X, I'm out. Once they're saying Y, I'm out. Because you've had practical experiences where you've said, not for me.
Well, in this case, I've never been there before where I've had to say, like, no, not me. But if it does come, if it does come to me, wow.
And Kiwan, I'm giving you a chance to think about it, the response. 'Cause I see the gears moving. I'm giving you a chance to think about it because it's easy to say, I'm thirsty, but I'm going to have this much water. It's very difficult to do if my thirst is down to here. It's also difficult to do if you tell me I must not only have this little bit of water, but I'm supposed to use a tiny straw and drink it little. Yes? And I'm dying of thirst. Yes? As one person said, I'm drowning and you're describing the water. Yes? So when someone comes to you who has a quote unquote, and we use this in parentheses, normal sex drive of 3 to 4 times a week, they want rigorous sex, and Jamaica has advertised all sorts of rigorous sexual activities. And in their heads as a teenager, this is what they're coming for. You know, how do you compromise that?
Well, some things you just can't compromise. you got to put you first. You got to put your body first, your mental health first, your health first. I mean, you can bring your rigorous something all the way down there, but it's not going to happen here. No. And sometimes there's a difficulty of saying no. It's hard to say no, but I would encourage myself, me, Kiana, to, not give in to temptations.
And Ken, I'm going to put you as ambassador for saying no and finding all sorts of beautiful ways to say no. And Rev, I see you want to jump in, and I would love you to jump in.
I wanted to say that perhaps what that 30-something-year-old did in choosing a 20-something, you can train the person because you think you need as much water. But then if I were to help you to see that you don't need as much as you thought you did, because if you go in terms of the culture, you want to do what the culture says you're supposed to do. But then you can be satisfied by not doing all of that stuff. So I can train you that we don't have to have that rigorous intercourse, but we can both be satisfied if you're willing to be trained. And so I think that's the challenge.
A lot of caveats there, right? So I'm going to move back to Mr. Noble. Mr. Noble, to finish off the discussion part so that we can take questions. Do we have questions coming in, Doc? Dr. Tolleride? Because if not, I have other questions I want to ask, so let us know. Not yet. So, Mr. Noble, you hear what Rev says. He's giving you good advice, yes? Doc says she bring in the family or whoever needs to speak, and Kiana is working on her nose. She's going to be posted on social media all the ways to say no. For you, apart from the fact that you have this missionary zeal, medical missionary zeal to assist your partner, what has been your self-talk? What have you told yourself to reach a place that Rev would like you to get to, where you know you can be satisfied without all of the things that they say on the records, let's say. It's not a radio necessarily, but on the jukebox, yes? What has your journey been like to change that mindset?
Well, my journey is to still exercise that level of patience and humility, to wait on my spouse until she's ready. Sometimes she said no, and I have to accept the fact. When she said no, no is no. You understand? And work with her and to see how best we can work things out. However, we have a discussion night, every further night, and we discover at all levels. And we discover whatever challenge we have with each other. Because sometimes we may have heated moments because it's a real situation where we have to deal with it as spouse. And sometimes it's not good, especially when you have a child or children around you. You have to exercise a level of professionalism same way. So we have this family night where we meet together as family. And this is where we let down our hair and we speak our minds. Whatever is affecting each other during the week, everybody get a chance. Even my daughter, when she's ready to speak out, you have to really listen. And my wife, they speak their minds, what they're experiencing, what she's going through. I would do the same thing, and then we come to one consensus and say, all right, this is the way we're going to chart it forward. Yeah. And then we begin to put plans in place for, a recreational family thing. We go to a hotel or a beach or sometime to really get back things together.
So you're reinforcing there what Kiana said earlier, what Rev said earlier, even what Doc is saying about talking to the family, that the communication has to be with a purpose. Right. Not just talk for talk's sake, but I love the fact that you're organizing a time that the family speaks together, a time that you just let your hair down and you just be yourself and you say what's on your mind. But you also move it to a resolution. Right. You don't just air it for the sake of airing it. You do something about it. Right. So that's very, very helpful, and I think a lot of people could benefit from that tip you just gave. Thank you. And I'm going to bring it back to Doc. Doc, if I come into you and I'm diagnosed today and I say to you, but I want to do romping shop and all those things that I hear on the radio. That's an old one now, right? That's why I chose that one. That's why I chose that one. And I say to you, but Doc, tell me now, what is a healthy sexuality for someone like myself diagnosed with lupus? What can I expect?
And that's where it comes in that lupus is a journey, because it takes time to understand what your illness is and what your personal limitations are going to be. And the hope is that as we treat you and you get better, you'll be able to adapt and do more. So it really, once again, it's not only the spouse that has to be patient, but the patient has to be patient. And understand that we want you to have as close as possible a normal life with certain...
What does that mean? That's the one
Right.
describe me. What is a normal life?
Right. Maybe what
I know what a normal level of
societal's
sexual functioning is. I
Right.
can tell you, on average, a couple that's getting along well, 3 to 4 times a week is normal for the average couple that's getting along well. Those don't have to be 3 instances of intercourse, but are 3 instances of romantic sexual engagement.
Right.
Yes? So is that what you mean when you're telling me as a patient that I can have a normal life? I can have sex 3 times a week?
What I'm saying, we want you to have that, right? But you have to do it in the context of understanding there are certain considerations you may need to have that somebody without lupus may not have. And so some of it is going to be, can we try this time to see if this works for us? Have you thought about maybe us doing this instead? So it's really a learning process.
And I love that collaborative approach. I love that approach of can we? Because all the time I say that, you know, in therapy, I say can we? And I know it's them, I mean, I don't mean me. I'm not going home to do anything. But I say, can we try so-and-so? Yes. So I love that collaboration. I'm going to open the floor to any questions that you might have. I think there's a mic in the center there. And I'm sure you have questions for the marvelous panel. I'm really edified. Thank you so much. Anyone with a question? Missing Dr. Tullery? No. Yeah. All right. So I'm going to, if I don't get a question in 5, 4, 3, 2, 1, I know it's been a long day. I'm going to ask each of our panelists in a couple of sentences to just say to us what they'd like us to take away from this brief discussion here today. I'm going to start with my star, my social media star, Kiana, over there. Kiana, go ahead.
All right, good afternoon again, everyone. What I'd want us to take away from this discussion is that a relationship is, you know, a collaborative effort. Yes, we are lupus warriors. Yes, we're not feeling well, but then we also have a responsibility to our partners. And that being said, anything you do, it should not be a you do situation, it should be a we do situation. A decision that you both make, and your health should always come first.
Thank you. Pass the baton to the great Mr. Noble.
In brief, I would just say teamwork, because teamwork makes the dream work. So together, everyone can achieve more.
Thank you, sir. Graham?
I think you should put it in poetry, because she's a very good poet.
Yeah.
Yes, and I think it is being open to learn and grow, and I think dealing with those challenges that you may have brought into the relationship, and so you ask yourself, having this discovery, am I open to learn and grow with a person who I trust and who I care about? And both of us, it can be a learning process, as our brother has shown us. And I think that would be very important.
Just to say that as medical professionals, we do acknowledge that your lupus is a challenging disorder that affects every single aspect of your life. But always remember that you're not alone, and as medical science advances, we're able to improve what we have to offer our patients, and we promise that as time goes on, your lives will get better.
I think that's a fantastic promise to end on. Thank you all so very, very much. Blessings. And to the organizers, thank you so much. And that brings us to a conclusion of our panel. Dr. McClure.
Better panel. Give them a round of applause. As I listened to all of them, I was just astounded. There was so much wisdom here, so many pearls. I hope you all caught them, and not just for those with lupus, but for everyone. This was really very in-depth and thought-provoking, and I am so happy and blessed for our panel. Now I'm going to turn back over to my director, who will take it from here.
Thank you so much. Quite enlightening, engaging, and intriguing. Excellent information from you all. Thank you. I think we have some gifts to give out. Dr. Tanisha McGee-Phillip will come forward. Tanisha.
Kiana. Kiana has a very special place in my heart. I won't go into it, but every time I see her and hear her speak, I am just so proud, like almost like a mother. You're an example to your generation, and it's a multi-generational kind of influence that you do have because of your wisdom and your, sacrifice, and your giving back to the community has not gone unnoticed. It's not just about today, it's about all that you've been doing for all this time. We love and adore you, and we wish you all the very best with everything that you do. Thank you for today. Mr. Jerome Noble. My husband should be here to listen to you. He's good, but he could really do pick up, some great points. It was really inspirational. You are truly, husband, father, and you own it. And that zeal that Dr. Carpenter spoke about is really inspiring, and I think many people would leave here with lots of pearls, practical tips, and really feel, that they can do because you have done. We thank you for sharing today, and we wish you both all the very best with everything. Carpenter. What do I say? You're just amazing. And you've just opened up a world that, that a lot of us don't really venture into, we don't speak about. And you've done so with such wealth of information, such poise, such grace, and such frankness. And we really do appreciate what you have been doing and what you have done for here today in terms of putting it in the context of lupus. And we wish you all the very best. Thank you so much for your contribution to this year's symposium. Oh, you have to come back for your... Oh, dear. Double for your trouble. Double for your trouble. It was a trouble. Thank you. Stacy, we love you. All right, I'm going to hand over to Mr. McDonald to continue. Thank you so much.
Thank you, Dr. McGee Phillips. And again, thank you very much. It was really fantastic. Well, we have come to that time at the end of the program. I think I just want to thank everyone for coming in person and online. I want to thank our indomitable President, Dr. Desiree Toller-Reed. I think I can safely say she's a lady of tenacity, audacity, and perspicacity. Eh? And to your extended team, the immediate team that we worked along with, congratulations. Congrats to the admin team at the office and to the team of volunteers outside and inside. To the audiovisual team, congratulations, you were well equipped. To the presenters, all the presenters, they were fantastic, amazing, and a wide range of topics were covered, and I think I gained more than I gave today. And I'm very grateful. It reminds me what Zig Ziglar said, the more that we're grateful for what we have, is the more we'll have more to express gratitude for. And you see, when we meet like this, what we do, we deepen our lives. And Joshua Loth Lieberman, writing in the 1940s, in his book Peace of Minds, he said that let us deepen our lives where we cannot lengthen our lives. Let us make up for the brevity of life by heightening the intensity of life. And I think that is the mantra that we have to live by, you know. And sometimes, you know, when I listen to young Kiana and all of the challenges, and she goes through with such a glow. And sometimes you wonder, you know, when God places us for what we call difficulties. I remember when Mahatma Gandhi, when he was thrown from the train in South Africa in 1899, and in New Delhi at the Gandhi Museum, the centennial, on the wall, the speech said, Gandhi was not thrown from the train in 1899, he was flung into greatness. Wow. And I think out of adversities, something blooms, and people with that kind of perspective, the warriors, you will be you bloom wherever you're placed. And I think that with the grace of God, you know, and that power, they'll keep going on. I want to thank all our sponsors, the National Health Fund, and they have been on board for many events, Wisynco, Co-Create, IPCA, Jamaica National, Flow and Flow Foundation, Auto Channel, Concept TC, Ophthalmic Suite, right? Axel, Spa, Aesthetic, Realism, and Imagination. I want to thank you all. Some of these sponsors have been with us for many, many years. We want to thank again the audience in person. You have stayed with us. And some of you came as a couples and you will leave as a couple. Again, it has been my wonderful pleasure, and feel quite humbled that I was asked to, you know, chair this proceeding again for another time. And thank you so much. May you walk in peace always. Thank you very much.